What's up, Ninja Nerds? In this video today, we're going to be talking about CNS infections. That's primarily going to focus on things like meningitis, encephalitis, and brain abscesses. We'll talk about a couple other things along the way, but that's going to be the primary focus. Again, if you guys are really enjoying these videos, you feel a little bit more confident about these topics, you feel like when you come to the exam, you feel like you can just crush it, then support us. You can do that in a couple different ways. Hit the like button, comment down in the comment section, and you can subscribe. Also, highly urge you to kind of consider this. Go down in the description box below. There's a link to our website. On our website, we have a lot of different things to offer. Notes, illustrations, quiz questions. We're also developing other things like flashcards and cue banks. So go check it out. I don't think that you'll be disappointed. All right, let's get right into it and talk about CNS infections. So again, when we talk about these, it comes down to meningitis, encephalitis, and brain abscess. So in simplest definition, and if I asked you, okay, how would you define meningitis? It's the inflammation of the meninges, right? And so the meninges consist of a couple different components. You have the pia mater, the arachnoid mater, and the dura mater. So it's inflammation of those meninges, usually due to an underlying infectious etiology, which is why we're talking about this in infectious disease. Encephalitis is inflammation of the brain parenchyma, usually due to an underlying infection, right? Now, we'll talk about this a little bit later when we get into more of the etiologies. A lot of times, patients can have a combination of meningitis and encephalitis, and that is called meningoencephalitis. It's the inflammation of the meninges and the associated, probably localized nearby, brain parenchyma. And the last one is a brain abscess, and that's kind of a walled-off infection containing just usually pus material or non-purulent material that's in a walled-off capsule. And this is usually occurring in the brain parenchyma. What I want you to think about is these are all usually infectious in etiology. Let's talk about how do these pathogens actually gain access into the central nervous system. And there's a couple different routes. By far, probably the most common are going to be these two. So hematogenous means the pathogen kind of gets into the bloodstream. It crosses a mucosal barrier of some sort, or it gains access to our circulation. From there, it moves through the circulation, and it then can seed into the meninges, into the brain parenchyma, and lead to its unfortunate damage. So let's talk a little bit about hematogenous spread. So let's imagine here for a second that we have a pathogen and it's kind of gained access into the circle of Willis. Circle of Willis, you have the anterior circulation via the internal carotid arteries here. So here we're going to have the internal carotid arteries, which are going to be giving the blood flow to the anterior portion of the circle of Willis. And then over here we'll have the vertebral arteries, which are going to be supplying the posterior circulation. That's what we know about this kind of flow. What I want you to think about here is what are ways that we can get pathogens into the cerebral circulation, and then from there they kind of float out into the meninges and infect the meninges, or they get into the brain parenchyma and cause encephalitis, or they get into the brain parenchyma and cause like a focal area of inflammation, infection, and then a pus-like material that gets formed a capsule around it. Well, I think what's really interesting is one of the most common ways is usually what's called nasopharyngeal invasion. Now, when we talk about this, most of the time, and there's a couple different pathogens that I would be concerned about, especially bacterial. So there is one called Streptococcus pneumonia, and there's other ones like Haemophilus influenza. There's other ones, for example, things like Neisseria, meningitis. These are pathogens that they can kind of be within the nasopharynx, and they may colonize, they may build up there. And for whatever reason, maybe the person develops kind of a breakdown in their overall immune system and their ability to kind of prevent that from getting past the mucosa. Once this, let's say that we have these small little vessels back here in the nasopharynx, right over here. Let's say here's kind of some vessels, right? If this gains an opportunity to just kind of invade past this mucosa and get into the bloodstream, that's where we kind of get these problems. And again, I think it's important to remember that there is a couple different species that we should really consider as really common here. One is called Streptococcus pneumonia. So I'm going to abbreviate that one as this. All right? That's probably one of the most common mechanisms by which Streptococcus pneumonia gets its way into the bloodstream, is it seeds its way past the nasopharynx mucosa into the bloodstream. There's other ones that I would actually think are worth remembering are going to be things like Neisseria, meningitis, and another one is called Haemophilus influenza type B. So we'll put here Neisseria, meningitis, and the other one is called Haemophilus, and we're going to put H flu type B. These usually can colonize around that kind of nasopharyngeal mucosa. Usually streptococcus is going to be one, and then here maybe you have a diplococcus for Neisseria, and then maybe you'll have some type of gram-neg for the Haemophilus influenza. But either way, they're colonizing, you get kind of a breakdown in the barrier there, maybe a weaker immune system for whatever reason, and boom, these things fly right into the actual bloodstream. Now imagine here for a second, these pathogens gain access. So let's say here's some pathogens, they get into the bloodstream. If they get into the bloodstream, they can move their way up via these vessels, right? And then from here, if they get into the circulation, that's one way, right? Same thing here, they can move their way up from the posterior circulation and gain access into this kind of circle of Willis. Or you can have these pathogens moving up via the anterior portion, the ICA, and they can get access. Either way, these things are now in the vascular system. Once they're in the vascular system, the thing that we get concerned about is, let's say that these make their way into the MCA territory, makes its way into the MCA territory. Well, now these pathogens can do a couple different things. One is maybe they could just move their way right across that blood-brain barrier, and they kind of start causing maybe like a focal area of inflammation. And then that focal area of inflammation gets a little bit worse. And eventually it starts to become necrotic. And then as it becomes necrotic, it starts to form this walled off thing called an abscess. And let's kind of represent the abscess as having some purulent material inside of it. So this is one thing that I would definitely consider. So this right here is what we would refer to as a brain abscess. And it usually starts off as cerebritis. So oftentimes this is more of a progression where you have something called cerebritis, which usually starts off early, days 1 to 4, and then it kind of starts to get liquefactive around days 4 to 10, and then usually it walls off and makes this nice capsule at days 14 plus. And that's usually where you'll eventually get this thing called a brain abscess. So brain abscesses can form pretty simply from pathogens getting into the bloodstream and crossing the blood-brain barrier. Another thing here is, same thing, let's imagine this gains access into the circulation, it moves through here, and sometimes some of these pathogens cause a significant amount of inflammation. They cause a really, really nasty amount of diffuse inflammation throughout this actual lobe or this portion of the brain. Sometimes if it's really, really diffuse inflammation, we can call this encephalitis. So we can call this encephalitis. Now this can happen due to hematogenous spread, but we'll talk about this a little bit later. Oftentimes the most common etiology is usually something called retrograde axonal transport, because it's a way by viruses getting access into the CNS. The last thing I want you to think about is, what if these pathogens get here and they cross over? So here's the blood-brain barrier. This could go into the CSF. So they can get into what's called the blood-CSF barrier. They can cross and get into that choroid plexus. Maybe they get into your ventricle systems, right, which are in here, or they get access eventually into that subarachnoid space. If that happens, and these pathogens get into the area of the meninges, that's when we start experiencing some inflammation of these meninges. And that's when we see these patients developing something called meningitis. All right. Out of all of these, I would say the most common ones to usually have these conditions occur due to hematogenous spread is usually going to be meningitis and brain abscesses. And what's a very common way by which this occurs? It's usually things like streptococcus pneumonia or Neisseria meningitis or Haemophilus influenza type B via nasopharyngeal invasion. They cross that area. Another route is, let's say that I have a person, IV drug abuser, they got some kind of device that was placed, maybe they got a pacemaker, they had a cardiac surgery, whatever, but they have maybe some underlying, heart valve disease. And what happens is they form vegetations on their mitral valve, or maybe they form vegetations on their aortic valve. And these are infective what we call infective vegetations. They contain bacteria, pathogens. And oftentimes there's a bunch of ones that we could consider. I'd say the ones that you definitely want to think about is your Streptococcus viridans species. And another one is going to be like your Staphylococcus aureus. These are probably going to be, and we get really worried about MRSA for this one, but these are usually going to be something concerning for these types of pathogens. What's problematic with this condition is that in this condition, when you have these like nasty infective vegetations, if they kind of break off of the valve, if they break off the valve, I now have these freely circulating things called septic emboli. And now these septic emboli can just move along. This thing can move right up the left ventricle into the aorta, or they can break off of the aortic valve into the aortic circulation, and then they can go right up into your systemic circulation. And now I got septic emboli causing this. What's the condition that leads to septic emboli that can then spray this thing up and shower it into your actual brain tissue? That's called infective endocarditis. So infective endocarditis is a very, very common way by which we can actually seed and spread these pathogens. All right? All right. Now, the next one. Now, these can come from anywhere. So when I say hematogenous seeding, this tends to be the one that we kind of really want to think about as the nasopharynx. It's just probably colonization, probably exposure. And again, they can stay there. They act like commensal bacteria a lot of the time, or commensal kind of organisms. And if you have some kind of like breakdown in the actual overall immune system or barrier, they can invade. That's just how these kind of things work. But this one is usually an underlying infective condition. And there's another scenario. What if I have a really nasty infection in the lungs? Really nasty infection of the lungs. Or maybe it's not just an infection. Maybe this thing is a true abscess. All right? These are also very, very common reasons that these pathogens can kind of seed into the bloodstream. They have the pulmonary circulation nearby, and so all these have to do is just get access to the pulmonary circulation. And if they get into the pulmonary circulation, baboomskis, here they come on their way here to get into the bloodstream, right? And so this is usually something that we would see in really nasty pulmonary infections, usually conditions, for example, things like pneumonia, or maybe even a lung abscess. And these things can definitely gain access to our pulmonary circulation. Now, there's so many different pathogens, but I'd say probably the ones that I'd really want you to consider for this scenario is going to be Streptococcus pneumonia. And another one, which we can actually talk about a little bit later, especially in people who are like maybe more of the immunocompromised states. Maybe they had a transplant, maybe they have HIV, maybe they're on immunosuppressive medications. But there's another one called nocardia. So I think about Streptococcus pneumonia as a very prevalent type of pathogen here. And another one, in certain cases, I would think about nocardia, especially in the immunocompromised patients. But either way, we're seeing here how these pathogens are all gaining access to your circulation. And there's other conditions. It doesn't just have to be these. It's just these probably tend to be the most common ways of infective sources gaining access, or a person who's colonized and then they invade past that area. You can see this with urinary tract infections like pyelo. You can see this with intra-abdominal GI infections or abscesses as well. It's just they're going to be a little bit less common. And these are going to be the ones that I really want you to consider. All right? So that's hematogenous spread. What about contiguous spread? So what do I mean by this? It's not that this is gaining access per se into the arterial circulation, the circle of Willis, by which it can then throw these infected materials into the meninges, into the CSF, into the brain matter. This stuff, it can actually get in there, but it's going to spread via bone or like small little veins that are on the actual near these kinds of structures. So a couple things I want you guys to think about. Let's say that a patient has rip-roaring mastoiditis, right? So let's say that this patient, we'll actually do this right here. Let's say this patient has what's called mastoiditis. So it's one of their mastoid sinuses becomes infected with a pathogenic material. So we'll say there's some pathogenic material that's actually going to be in this particular area, all right? Or let's say that they have what's called acute otitis media. So acute otitis media, which is an infection of the middle ear. So here we're going to have the external ear, and let's say here we're represented with this like blue. We'll say this is the tympanic membrane. And then here is going to be the middle ear. And there's going to be some infection that's actually residing in that area. If this kind of happens, what can occur is that these can then easily spread their way right into the actual brain tissue. So from here, what you get worried about is if these spread through the bone right to the meninges, or they spread where? Right into the actual brain parenchyma. And so that's what we get kind of concerned about, is this infected material getting here and then eventually forming a abscess or triggering something like meningitis. Yeah, exactly, right? I know you guys were saying it, but you can start off with cerebritis, and eventually that cerebritis can then progress, unfortunately, to a brain abscess, which is kind of like a capsule that gets walled off, and you have all of that purulent material there. All right? Usually what we get concerned about with acute otitis media, right, is it definitely can cause meningitis and it can cause brain abscesses. I'd say it's much more common for you to see things like brain abscesses though. And so we'll talk a little bit about this for a second. So you definitely can see this condition here, which is going to be meningitis. And you're definitely going to see things like brain abscesses as a result. This deserves just a quick little discussion on something though. So when we talk about brain abscesses, I'd say that's the more common way by which you probably experience these kinds of infections. These CNS infections is probably contiguous spread from a source nearby where they just spread through the bone or they gain access to emissary veins. But I want to talk about this for a second. When the brain abscesses occur due to these two conditions, it's usually going to be in two locations. So the most common is, think about the actual location of where the middle ear and where the mastoid sinus is with respect to the parts of the brain. It's close to the posterior fossa, and it's close to the actual middle cranial fossa, which is where the temporal lobe sits and where the cerebellum sits in the posterior fossa. So the most common locations that I get worried about with these is going to be the temporal lobe and the cerebellum. So whenever you have these conditions where you have an abscess in the actual temporal lobe or the cerebellum, think about these as the two potential sources to that. Now, pathogens that we usually associate with these is more often than not, usually it's going to be something, you can have Streptococcus pneumonia for sure skis. You can also have Streptococcus viridans, and sometimes we don't see them a lot, usually more dental. You may see some anaerobes, but it's not too common. Usually most of the time with these infections, it's usually going to be things like, again, Streptococcus pneumonia, maybe some type of like Streptococcus viridans species. With acute otitis media, you can see Pseudomonas. I've seen Pseudomonas with like very chronic ear infections, patients who have diabetes or have an immunocompromised state. All right? But that's something to think about for these. Let's come over to the other aspect. Let's say that I talk about a patient who has maybe frontal sinusitis, right? So let's say frontal sinusitis, or they have ethmoid sphenoid sinusitis, or they have some type of periodontal disease. Periodontal disease. Usually these are like nasty abscesses. When we think about these, what I want you to consider is when patients have some type of, let's say, really nasty infection here in the frontal sinus, really nasty one maybe in the ethmoid or the sphenoid sinuses. If these spread, they typically can again spread where? They can spread to the meninges, or they can spread to the actual brain matter itself. Same thing, can spread to the meninges, or they can spread to the brain matter itself. If they do that and they infect these areas, you can get meningitis, or you can get what? Think about this. Let's kind of put this one right here, or put this one right here. What would be the potential things that could happen? You could start off with a little bit of cerebritis that then could progress to an abscess. Again, cerebritis. That could then progress to an abscess. And that's what we get worried about, is primarily these abscesses, these nasty little sons of guns, right? Where you get cerebritis progressing to an abscess is the things that I want you to definitely consider. All right. So with this, if a patient has frontal sinusitis, you can spread pathogens easily there. If you have ethmoid or sphenoid sinusitis, you can spread infections here. And if you have some type of periodontal disease, usually, for example, if you have like a really nasty dental abscess, these can seed that way as well. All right? And we'll kind of just bring this one here. where we'll show this same kind of event here, there or there. This is the key thing here. These will trigger the formation of brain abscesses. That's one thing that you can definitely expect. You can also expect something like meningitis, but I really want you to more likely associate this with the brain abscesses. When we think about brain abscess with these, the problem with these kinds of brain abscesses is the location and oftentimes the pathogen that we get kind of concerned about. Usually with brain abscesses from a frontal sinusitis, an ethmoid or sphenosinusitis, or a periodontal disease is more likely to involve the frontal lobe. So that's what we got to get concerned about with these, is some type of frontal or maybe even parietal lobe abscess. All right, but I'd say definitely consider this in a frontal lobe abscess. The reason why is when patients develop symptoms, headache, fever, maybe a focal neural deficit, you get a CT scan, you see this ring-enhancing lesion in the frontal lobe, you should start looking on the CT scan. Hey, is there any kind of really poor involvement of or a pacification of the actual sinuses, like the frontal, the sphenoid, the ethmoid sinuses? Is there any kind of dental processes that are going on that could explain this? And then correlate that with your physical exam. If I see an abscess that's actually a ring-enhancing lesion in the temporal lobe or the cerebellum, I should be looking. Is there anything going on with that middle ear? Is there anything going on with the mastoid sinus that could explain these processes? Same thing with a patient who experiences meningitis. Oftentimes, it's more likely hematogenous seeding. It's not as often that you'll experience it from a contiguous spread, but you can. All right? So we got that down, I think, pretty good. Let's move now to the next way that these pathogens can kind of get their way into the CNS. So they can get in via the blood. They can get in by spreading through bone or maybe getting access to small little veins that are nearby in the face. And you know why? It's because if you have small little facial veins, like little ophthalmic veins or emissary veins, they can actually really kind of get their way into the actual brain tissue. They can kind of access our cerebrovenous sinuses. And so oftentimes it's actually quite interesting. Patients who experience things like maybe frontal or ethmoid or sphenoid sinusitis, not only do they have a high risk of brain abscesses, they probably also increase the risk of a cerebrovenous sinus kind of condition. One of those we call cavernous sinus syndrome. We'll talk about it maybe when we get into the complications section, but they oftentimes kind of go hand in hand, where brain abscesses and cerebrovenous sinus thrombosis can kind of occur simultaneously due to the same kind of shared source. All right, cool. So we talked about pathogens gaining access via blood, pathogens spreading through the bone or through small little kind of emissary veins. What if they use the neurons to their advantage? What if we have pathogens that can do this? So what's kind of interesting is, let's say here, I have some nerves. We're going to kind of call this here. We'll say this is our olfactory nerve, right? The olfactory nerve. All right. Now, when we talk about the olfactory nerve, it's one of those that actually runs through the little space here called the cribriform plate. Let's say that you actually took, and this is a weird one, this is why it's an odd one. Let's say that you went into an area where, I don't know, maybe you had a sinus infection, and you're using a neti pot. Neti pots are kind of those old school things that you use to kind of help to move out some of the mucus from those nasal cavities. Sometimes what you're always told to do is to use the proper water source, usually some type of cleaned water, like a distilled water of some sort. You don't want to use water from the tap or something that could potentially contain pathogens. So sometimes you increase that risk when you increase this potential amoeba or parasite that can actually get into your, right into this area. Another one, we also consider this in the clinical vignettes, is when a person was out near a river or kind of a fresh water source and they dived in and that water rushed up their nose. The reason why is there's a nasty little amoeba, parasite if you will, that can gain access via this process. So what it can do is it can rush right up through the nose, and then what it'll do is it'll travel along the olfactory nerve up through the cribriform plate, where it can then cause and wreak absolute havoc to the actual brain tissue. And these patients can oftentimes experience things like meningoencephalitis, oftentimes. So oftentimes they're going to get a combination, something called meningoencephalitis. Now this is a pretty rough one. This one, most of the patients I'd say die. There's a high mortality rate with this one. That's why it's actually super important to remember it. But I want you to think about this again with what kind of trigger with a fresh water right up the actual nostril hole. So fresh water, I'm not kidding. I want you to remember it went up the nose. Somewhere in the clinical vignette, they're going to present this. Usually this is associated with Naegleria fowleri. So this is a really nasty type of amoeba that can actually cause this type of infection. But again, what it does is it uses these nerves as a way of being able to kind of transport itself up through the cribriform plate and gain access into the central nervous system. So that's one. The reason why I really want to stress on the retrograde axonal transport here, because this is technically, if we're being really, really particular, this kind of doesn't actually gain access and use the actual transport proteins along the axon to transport its way up. It just moves along the olfactory nerve up through the cribriform plate. These ones that I'm going to talk about truly do utilize retrograde axonal transport. Let's kind of pick a color here. Let's go with purple. And let's say here I have some nasty viruses. And these viruses are present. And what they're going to do is they're going to gain access. They're going to hop on to these axon terminals. And when they hop onto the axon terminals, they then can utilize these specific transport proteins to move them along the axon where they go and they kind of live in the cell body, which can be, again, these dorsal root ganglions. They can be inside of the cell bodies of the spinal cord. They can even move their way up into the ganglion of like cranial nerves as well. So what happens is they'll go here into the cell body, and they may kind of go into this period of where they cause damage, and you can experience some kind of symptoms. Usually, for example, if a patient got infected with some type of nasty lesion, maybe it was something like HSV1 or HSV2, they could exhibit certain types of cutaneous lesions, maybe some type of herpetic lesions that would actually take place, or genital lesions that would take place around the actual genital mucosa, or if it was the varicella zoster virus. This could then actually cause potential dermatomal rashes or lesions, vesicular lesions that can appear, and that's going to appear on a dermatomal pattern. Sometimes they're going to occur along the facial nerve where they get that Ramsay-Hunt syndrome. Either way, they can go and they can reap their kind of like overall damage. What happens is sometimes these viruses go into a period of kind of latency. So in other words, you kind of go where you have this process of where you have the infection, like the actual onset, then it moves into a period of a latency, so latency, and then from there it gets reactivated. And usually that reactivation of the virus is where we see these potential problems, and it's usually in an immunosuppressed state. So usually you'll have this hop on, it'll gain access to your neurons, move along the axons, gain access. Now it's in the spinal cord, or it can be near the cranial nerves. And then from here, this thing can move up, and it can then start to wreak havoc on your actual brain tissue. And usually this could be, I'd say most often it's the actual brain parenchyma, but it could be the meninges. But I'd say most often, more than not, you see these patients experience things like encephalitis. Every now and then you may see a little bit of meningitis, but more often than not, these are going to cause encephalitis. When this kind of process happens, usually they cause the infection of that particular skin area. They then access the nerve, they move in, they remain kind of latent in the cell bodies, and then in an immunosuppressed state, something happens to them, that virus reactivates. And then from there, it can then kind of travel along these areas to your actual central nervous system and really reap these kinds of damages that we can experience with these patients. The reason why I tell you this is because these are going to be the pathogens that we oftentimes most see do this. You can see other ones like rabies can do this as well, but we're not going to talk a lot about rabies, all right? So this covers another mechanism by which these pathogens can gain access to our central nervous system. Let's cover the last one. And it may seem weird, like the reason why I'm doing this, but I promise it actually is going to help when it comes to us taking the foundation of how we're kind of explaining this, which is the pathogen can gain access to the central nervous system through seeding of a pathogen into the blood, or spreading via the bone or via the nearby facial or emissary veins to gain access to the CNS, or they had a retrograde axonal transport where it kind of traveled along a nerve. And then last scenario is direct inoculation. The reason why I tell you these is when we start thinking about these patients who comes in with a fever and a headache, and maybe they have other symptoms like meningeal signs and cortical signs, and you're going to start going through, you're going to get your lumbar puncture, maybe you get a CT scan, you find out if they have meningitis, if they have encephalitis, if they have some type of process like a brain abscess. Then your job is to potentially think about where could this have come from, because it may guide your particular antibiotic of choice. And that's why it's important to think about this. All right, So let's come to the next component here, direct inoculation. This one's actually pretty simple. I'm not kidding. Imagine you got nailed with a tomahawk to the head. So you have some type of penetrating trauma. The concept behind this is if you have penetrating trauma, if that, let's just say you dip this tomahawk in like, I don't know, poo-poo, and it's got some kind of like fecal matter along it, you're a weirdo, right? And you're doing something like that. If this is dirty, it's got nasty pathogens on it, it can easily seed over here and it can just directly infect the actual brain tissue. And this is where you can definitely get things that we get concerned about, like meningitis, cerebritis, that can progress to a brain abscess, right? So that's one thing that I would definitely consider as a penetrating head trauma. And the reason why we consider this is that there's specific bacteria. And I'll talk about what those specific bacteria are in a second. So that's one, all right? The next thing I would also consider is any kind of neurosurgical procedure. If I'm popping this person's top, right? If I'm popping that top, if I'm cracking a piece of the skull off, I'm doing a craniotomy, a craniectomy, I'm going in, I'm doing a burr hole. Anytime I open up the brain matter and the actual brain itself to exposed pathogens everywhere in the world, that stuff can just get its way right in. So I like to think about this with any kind of like neurosurgical procedure. So any kind of neurosurgical, I should say neurosurgery of some sort. Any kind of neurosurgical procedure where I'm removing a piece of the skull, I'm using some kind of like burr hole, craniotomy, craniectomy, I'm accessing their actual dura mater or their brain, it's a direct route. Any kind of bacteria that's in the vicinity, anything that's on any, it should be always sterile. But if there's some chance that there's a non-sterile instrument, that pathogen, it just gains direct access. And so if it can travel along this area right into the brain or into the meninges, I mean, come on, we know what's gonna happen here. I've said it about 3,000 times, right? You can get some cerebritis, and that could progress to potentially a what? An abscess, right? Or it can get into the meninges, and you can get meningitis. So that's what I want you to think about here, all right? The last thing is, what if I put a device where maybe I have to have a small little burr hole, but I'm running a device into a ventricle, like an EVD, or I'm rerouting that down into the peritoneum with a VP shunt, or I'm accessing an actual reservoir for me to inject like intrathecal therapies like chemotherapy, like methotrexate. Those are all kinds of scenarios where I increase the risk of pathogens traveling along this tunnel source, right? And then into the ventricles, and I can get ventriculitis, into the meninges, into the brain matter, where you increase the risk of abscesses. I think you get the point. This is a tunnel by which all of these things can potentially lead to infections. So this is where we get worried about like any kind of device. And I think like cranial devices, spinal devices, let's just say for now, maybe in this scenario, we're gonna use some cranial devices. This is where I would think about maybe a couple different things. If you see it in the vignette or you're on the wards, I would think about things like an EVD, a VP shunt, and maybe an Ommaya reservoir. They're not too common, but you may see it on the oncology ward. But EVDs, these are usually more acute in scenarios of acute hydrocephalus or intraventricular hemorrhages. A VP shunt, which is going to be more of a long-term scenario for things like communicating hydrocephalus or congenital abnormalities. And then lastly could be a Ommaya reservoir. Usually these are going to be things more for the intrathecal therapies like chemotherapy of sorts. All right? So reason why I tell you all of these things is that in these potential scenarios where you have a cranial device, you have a neurosurgical procedure, or you have a penetrating trauma, these increase the risk of very specific types of pathogens that I get concerned about. Those pathogens usually are going to be, as such, I would get worried about, we call these coagulase negative Staphylococcus epidermidis, right? Another one is called Staphylococcus aureus, but the more specific component of this is MRSA. And the last one I get concerned about is Pseudomonas aeruginosa. These are the particular pathogens that you want to think about in the scenarios of direct inoculation. Because the reason why that's important is it guides your antibiotics of choice. Usually these are things like vancomycin and some type of thing like cefepime or meropenem or ceftazidime. Whereas things that are usually due to contiguous spread, you're covering more particularly things that are like you get concerned about with like usually streptococcus species and anaerobes. So maybe more your gram positives and anaerobes. Things that are usually hematogenous, you're covering primarily probably your gram positives, and you're covering some gram negatives as well. So that's what I want you to think about in these scenarios, and I promise this will come and make more sense as we move into the next sections like causes. It'll also make a lot more sense when we get into the treatment. The whole point of infectious disease is you want to do your best to tie what is the true underlying pathogen that's causing this disease. There's a lot of times that we use empiric therapies. Your goal is to then narrow those things down, or at least what's the most likely pathogen for me to cover this empirically. Let's move on now. All right, so let's talk about the etiologies now. So again, I think this ties a little bit of this together to think about when patients have acute bacterial meningitis, right? Because the meningitis can be acute bacterial, it can be aseptic, or sometimes we call that more particularly viral meningitis. And why we say aseptic and viral is because, again, the most common etiology usually of aseptic meningitis is viral meningitis. It could be due to drugs, and there's other etiologies along the way, but we're going to stick with viral for right now. And then there's these rare types of meningitis that you may be tested on, but we'll probably talk about these more individually in their own lectures. And usually these are things like TB meningitis, things like cryptococcal meningitis. You may see Lyme, Rocky Mountain spotted fever related meningitis, neurosyphilis, that guy's always in there somewhere. Treponema pallidum's always jacking up people. So those are the ways I want you to think about it, as usually acute bacterial meningitis, aseptic viral meningitis, and then kind of like your rare ones that really we only think about if they have specific host risk factors or exposures per se. All right, so the reason why I want you to think about meningitis is, again, it's inflammation of the meninges, usually due to an underlying infection. So if we think about the areas by which these patients will have this, the meninges, the problem with these is that it's so diffuse. So it's kind of really widespread. And that's what we get kind of concerned about with meningitis here. So this can be pretty widespread. So that's what we're going to think about with meningitis, is usually there's an inflammation of the meninges. It can be pretty diffuse. It can be pretty widespread. What I want to then kind of say is, okay, let's talk about meningitis in the forms of acute bacterial, aseptic viral, or the rarities, those zebras that we don't often think about. Then what we're going to do is we're going to take acute bacterial meningitis and we're going to break it into community-acquired pathogens and hospital-acquired pathogens. And the reason why is we'll talk about a little high-yield factor that you're going to be tested on, which is the type of antibiotics. So in acute bacterial meningitis, there's a couple different pathogens that I want you guys to think about. First one, and by far the most common, is going to be streptococcus pneumonia. Sometimes we call this like pneumococcal meningitis. This is by far the most common. And again, let's kind of link it back to the route. Which is the most common way by which you can get this type? It's usually the hematogenous seeding. It's the nasopharyngeal mucosa by which you can actually get into the bloodstream. There is other ways you can definitely get this from, pneumonia as well, and you can definitely even get this from contiguous spread. It's just more likely, more often than not, we're going to see this from hematogenous kind of seeding from a nasopharyngeal mucosal source, maybe some type of acute otitis media, maybe from pneumonia, but more often than not, the nasopharyngeal mucosal invasion. All right, with this, and the thing I want you guys to understand is that this pathogen, it's going to be in the nasopharynx. So what pretty much increases your risk for this particular pathogen? And there's a lot of different things that I really think is important. So when we think about this one, if they presented a patient with meningitis, acute bacterial meningitis, you could pretty much have no other kind of risk factors mentioned. You probably suspect it's streptococcus pneumonia. You'd be pretty close and you'd be pretty good if you made that guess. But any kind of preceding, I'd say, pneumonia, acute otitis media, sinusitis, or any kind of upper respiratory tract infection per se, really suggest it's a high incidence of streptococcus pneumonia that's causing this type of meningitis. Another one that I definitely want you guys to think about here is if a patient has cochlear implants. Cochlear implants really increase the risk of these particular pathogens kind of getting their way in, all right? So that's another one that I want you to think about. Other things that I would consider for streptococcus pneumonia is usually going to be a person who doesn't have a spleen, they aren't up to date with their vaccination, they haven't kind of kept up to date with their vaccination. So those are other kind of things that I would consider, is maybe a patient with asplenia, This could be due to sickle cell. That's usually oftentimes the things that they can think about, or they had a splenectomy for whatever reason. And another one that I would also consider, as we talked about here, is maybe under-vaccinated. Maybe they weren't sticking up with their vaccination status. I'd say out of all of these, the ones that they're probably going to try and test you on is going to be related to this. A patient who had a preceding pneumonia, acute otitis media, sinusitis, really puts this kind of pathogen on the top of the list for the most likely trigger for this patient's acute bacterial meningitis. All right. The next one that we also want to think about is Neisseria meningitidis. So this is, again, a streptococcus species. This is a gram-negative diplococcus. So this is going to be my Neisseria meningitidis. This one I think is really important to remember as well. When we talk about Neisseria meningitidis, the thing about this one is that it'll present in a couple different ways. We'll talk about it a little bit more in kind of the complication section. But this one, we think about it usually in those who are going to be in more, so this is spread via these respiratory droplets. And so those who have very, very close contact with very large populations, you're in very close with other individuals, so any kind of crowded environment. And so these crowded environments, I would say, let's say dorms. It's probably less common though now in dorms because we require vaccinations. Any kind of military barracks, right? You could even think about nursing homes. Those are things I would think about particularly for this kind of risk factor. So think about a crowding kind of environment where they were in a dormitory, they were in a military barrack, they were in a nursing home of some sort, and they had a close kind of contact exposure with an individual with Neisseria meningitidis. Another one is we think about this in patients who have some type of complement deficiencies. So this one's a little odd, but complement proteins are really, really important for being able to kill Neisseria meningitidis, right? So complement proteins is basically you have your, whenever you have an antibody that binds to a pathogen like Neisseria, it activates your C3 complements and usually your C5 complements, which are really important for membrane attack complexes. They help to opsonize the pathogen and make it easier for the phagocytes to eat them. So these are really, really important. So a patient who has some type of complement deficiency of some sort is really, really important. Now, going with that, a lot of the times they may ask this, and that is that they're on a drug called eculizumab. And eculizumab is a drug that we give to patients who have something called paroxysmal nocturnal hemoglobinuria. Basically, in the vignette, you'll have a person who wakes up in the morning. When they wake up in the morning, they have very, very dark urine. If you were to get maybe a spot CBC at that point in time, you would find that they maybe had kind of a hemolytic anemia. And usually this is due to a mutation in what's called the PIG-A gene, and they have this kind of complement activity that's causing the lysis of these red blood cells. Well, you give eculizumab to inhibit things like the C3 and C5 proteins, particularly C5. And that basically inhibits the membrane attack complexes. So it puts them more susceptible to infections from Neisseria meningitidis. So that's what you want to think about. And then the last thing we think about with this particular pathogen is, again, the same thing, is those who don't have a spleen. Okay, actually, I didn't explain that before. Why does not having a spleen, or whether your sickle cell actually caused a loss of the spleen, or you had to get a splenectomy for whatever reason, why does that put you at very high risk for infections from Streptococcus pneumoniae, Neisseria meningitidis, and we'll talk about another one, Haemophilus influenza type B? It's because the spleen is crucial to getting rid of encapsulated bacteria. So if you don't have the dang spleen, you can't get rid of those encapsulated bacteria. So it puts you at risk. All right, that's what's important here. So we think about this again, same thing. Those who ain't got no dang spleen, or if they were not vaccinated. But again, one of these things that usually is important is that we require these vaccinations to be up to date, to go to these particular kinds of institutions, or whatever kind of process that you're going through. All right, next one is Haemophilus influenza type B. So H flu type B, this one, again, I think it's kind of the same thing, where a lot of the times we think about asplenia, we think about the under-vaccinated population that are the most particularly at risk for this one. I say this is a less than 10% etiology for acute bacterial meningitis, but it is something to think about. So again, we'll write down this one, really, really high risk in those who have asplenia or a splenectomy, or they're under-vaccinated. All right, let's come to the last one here. The next one that I want you guys to think about here is going to be Listeria. So Listeria is a nasty son of a gun, man. Listeria monocytogenes. Let's write this one down. Listeria monocytogenes. This one here is really something that we only consider in those patients who have a couple particular risk factors. The way that you get usually streptococcus pneumoniae, Neisseria, and H-flu is most often via respiratory droplets, all right? So respiratory droplets, they kind of get into those nasal pharyngeal kind of airways, and that's why they colonize. And if there's a particular problems where you have any of these conditions, put you at risk, they can invade, they can get past that mucosal barrier, get into the bloodstream, or even when they get into the bloodstream, they're supposed to be broken down, they're not broken down, and that's when they can wreak havoc on the body. Same thing here, Listeria has very specific risk factors. This one's not really via respiratory droplets. This is actually spread through, it's weird, it's through kind of like particular deli meats. And so deli meats, if you're going out there eating Lebanon bologna sandwiches for lunch, hey, maybe back off if you have these particular risk factors. Other things is like unpasteurized cheeses and things of that nature. It puts you at risk. Now you can eat these things and there's gonna be Listeria in it, but if you have the immune system and none of these risk factors, you shouldn't really have to worry about it. But these are the patients that we do get concerned about that I'll mention. So the particular risk factors that you should definitely think about is age. So any age, particularly greater than 50 years of age, right? Another one is alcoholism. And those conditions that usually go along with alcoholism, that usually is a result of alcoholism, is cirrhosis. So we think about those who are, suffering from alcoholism, but also suffer from the undesirable complication of that, such as cirrhosis. Another thing is AIDS. And I really like to add this because you're kind of noticing maybe a trend here. Ooh, that was loud. Age, alcoholism, and then we'll add another A, which is going to be for AIDS. But really, this is more just to help you remember that it's any immunocompromised state. So that doesn't just have to be a patient with AIDS. That could be a patient who has a transplant. They had a solid organ transplant recently. They're on some type of immunosuppressant. Maybe they're on a steroid of some sort, a high dose. That's something else to think about. And the last one is, this one's really a stretch, but man, they pregnant. I don't know why it doesn't really work, but I don't know. We're just gonna go with it. They is pregnant. So a pregnant woman. In this particular scenario, the reason why is because in pregnant individuals, if they do have this potential scenario, they may have some TH cell kind of like changes, like immunity-related changes, but if that pathogen gets into their bloodstream, the worry is that it can be transmitted via the placenta to the fetus. That's why we really get concerned about that. And we really, really urge pregnant women to stay away from things like unpasteurized cheeses and deli meats and things of that nature. But these are the particular pathogens. And so the real kind of thing that I want you to take away is Streptococcus pneumonia, by far the most common. Really think about it in these potential scenarios. For Neisseria meningitis, you're probably going to more likely see it in this particular kind of like scenario. And there's some other things that we'll add on here. Usually with Neisseria meningitis, this presents in a very, very classic clinical scenario. I'll talk about it later, but usually they present with what's called a petechial purpuric rash. And they can also cause things like DIC, and they can cause things like septic shock, and they can cause things called Waterhouse-Friderichsen syndrome. We'll talk about that more as like the worst case scenario to correlate and think about with meningitis. But usually that's one thing that'll just tee you off, is you have a person who was in a crowded area, now they have petechial purpuric lesions, they have symptoms of meningitis, they're bleeding, or they're clotting abnormalities that are present on their labs, and then on top of that, they are very, very sick, hypotensive, and they have a lot of electrolyte abnormalities in sodium and potassium and glucose, all right? H-flu, really the under-vaccinated population, and then thinking about these particular triggers makes you consider Listeria. I promise we're gonna wrap this up and think about this clinically in a second, but before we do that, we gotta wrap it up with this concept. With acute bacterial meningitis, it can be hospital acquired. It's just like pneumonia. If a patient develops bacterial pneumonia, acute bacterial pneumonia, we have to think about this. Is this a community-acquired one? These are oftentimes the triggers. Or is it hospital acquired? Is it from a potential ventilator tube? Is it because they were exposed to something in the hospital that put them at risk? Same thing here. Is there a hospital acquired pathogen at risk here? Because oftentimes patients will come to the hospital with meningitis. It's not often, it's rare, really rare that they're in the hospital for something else and they develop meningitis, unless they've had specific types of procedures. So the thing I want you to think about, and we already talked about it here with direct inoculation, is think about this with coagulase negative staphylococcus. Another name, just so you know, is called Staphylococcus epidermidis. Write that down. Staphylococcus epidermidis is a coagulase negative staph. Another one is Staphylococcus aureus, but which one do we care about? MISA or MRSA? Methicillin resistant is what we really care about. And the other one to think about is Pseudomonas aeruginosa. These are the particular pathogens that you have to be considering. And again, the whole point here is that a lot of these are being spread by what process? Hematogenous seeding, or contiguous spread by which these can get access to our CNS and cause meningitis. This is via direct inoculation, right? And this is going to be things where they had some type of trauma. I like to think about these in CSF leaks as well. Like if you have like a basilar skull fracture with a CSF leak, that can cause this potentially process for these pathogens to gain access. Any kind of neurosurgery or a procedure that they've had, or any kind of devices that they have placed and are dwelling in, which can create a tunnel or a tract for these to get in, EVDs, VP shunts, or myoreservoirs. The reason why I want you guys to think about it like this is, if a patient comes into the hospital, they're presenting with a severe headache, acute onset. They're also presenting with a fever. They're also presenting with some meningeal signs, which we will talk about, and you suspect acute bacterial meningitis. The most common pathogens are going to be these. And in the very, very rare select scenarios, you may have these. They got in either through hematogenous seeding or they got in via contiguous spread. You'll have to figure that part after you diagnose their condition and you say, oh, the LP came back when the gram standard culture came back, it came back with streptococcus pneumonia. Where did it come from? We have an idea of where it came from and we can think about that. But here's what I want you to think about. The reason why this is important is when we think about patients who have, let's say for example, the community-acquired cases. Oftentimes the one that we're trying to cover for is streptococcus pneumonia, Haemophilus influenza type B, and Neisseria, all right? So Neisseria, meningitis. These are the three most common pathogens. And so with this, we want to cover for these particular pathogens. Listeria is only common in a select few scenarios. And so for this, you know what we go with? We oftentimes go with something called vancomycin plus ceftriaxone. All right, ceftriaxone. So that's oftentimes going to be our go-to. And this is usually pretty excessive, to be honest with you, because a lot of the times you could probably get away with ceftriaxone because that would cover all of these. But in some scenarios, we've seen some potential resistance to ceftriaxone by streptococcus pneumonia, and that's why we add on the vancomycin. But ceftriaxone will probably cover all of these properly. The next thing that we think about is there listeria? So if there is listeria and we have one of the A's, which I know this is like, it's a little bit of a stretch, but you have any of these potential risk factors, they're greater than 50, alcoholic, cirrhotic, they're immunosuppressed, or A is pregnant, then you add on a particular agent. You add ampicillin to the mix. So what does that mean? I'm on vancomycin plus ceftriaxone and I add on the ampicillin. So that's why we think about this, is because then if there is the particular risk factors, we're adding that one on. The only other scenario is, does the patient have a hospital-acquired risk? So maybe you're worried about that coagulase negative staph, you're worried about MRSA, you're worried about Pseudomonas aeruginosa. And these scenarios, you have to be able to cover for these. And the concern is usually MRSA and coagulase negative staph would respond pretty well to vancomycin, but ceftriaxone won't cover Pseudomonas. So what would you need instead? Some type of anti-pseudomonal coverage. And again, we'll get into this more in the treatment section. I just want to tie the etiology to the treatment for you. And that is when we go for something, oftentimes more than not, vancomycin plus cefepime. Another really good option that we'll get into a little bit later is another one. I'll actually write it down. So it's or meropenem. Meropenem. But these are the goals because vanco is going to cover the coagulase negative staph. The MRSA, Pseudomonas aeruginosa, will be covered by the cefepime or the meropenem. So this is why I want you guys to understand the etiologies and to understand how these things get access, because it helps you to think about your treatment appropriately. All right, we covered the really, really feared one. Acute bacterial meningitis, this is the scary one. You have to recognize this one. And the reason why is this, if not treated properly, carries a high risk of mortality. All right, if you continue to go untreated and you don't recognize this one, this carries a high rate of mortality. Even if you treat it, it still can carry a high rate of mortality. This one's going to present very acutely. They're going to be sick as shat. All right, so you have to be able to recognize this one. This one, it's not as bad. They're still going to present with symptoms of headache, and they're going to present with symptoms maybe of a low-grade fever, and they may present with some meningeal signs, but it's usually not going to be as severe. With these, we don't often do anything about these, unless it's the rare etiology that can be possible, like HSV2 or VZV. So let's actually think about these. If it's HSV2 or maybe even VZV, these are things that we actually consider. The only time you would even consider these is if the patient had particular risk factors for that. And the reason why we actually consider this one is this is the only one that you can do something about. Do you guys know what that is that you can do something about with this one? You can give this person acyclovir. All the rest of them that we'll talk about, you don't do anything. It's supportive care. You treat them as, treat their fever, treat their headaches, treat any other kind of neurological complications that they have, but you're not giving a specific agent for that condition. So these are the ones that you have to worry about. And really, it should kind of go hand in hand. Look for particular lesions. So for example, if I think about these, genital lesions are dermatomal, like vesicles, right? So maybe some genital lesions. They got some bumps on their the ding dong. So genital lesions you could be concerned about, or some type of vesicles. So maybe like the dermatomal kind of pattern. So a dermatomal rash. We'll get rid of this one. A dermatomal rash or vesicles. Dermatomal pain, and maybe some vesicles that are popping out that kind of make you concerned. That would signal more of the VZV. This would signal more of that HSV2. Funny enough, the more common etiology for these is usually what we call our enteroviruses. So enteroviruses are usually going to be two particular ones. One is called the echovirus, and the other one is called the Coxsackie virus. I know, it sounds like a really weird, like a made-up virus, I know. But echovirus and the Coxsackie virus, these are kind of nasty ones, and usually they're seasonal. So probably like summer, early fall, you may see some outbreaks. So what we usually think about for these ones is usually a summer-fall outbreak of viruses, and they'll present kind of interestingly where they'll have two things. One is they'll either have an upper respiratory tract infection or some type of GI infection plus a rash. So usually these would signal that a patient may have some type of viral etiology going on, as an upper respiratory tract infection or maybe a GI infection, maybe like an enterocolitis of some sort, plus an underlying kind of maculopapular rash. That may make you think about a potential viral etiology. And if that is the case and you end up getting a whole CSF panel, you find out that they have maybe more of a viral meningitis, encephalitis type of picture, and you do a PCR and you find out it's due to the enterovirus, guess what you do? You do nothing. And that's why it's important to remember that. But funny enough, these tend to be the most common etiology. So whenever a patient has, if you were to kind of say, hey, if I told you what was the most common etiology of aseptic viral meningitis, you would say this. And so what would you do for it? Nothing. And that's why it's really important to remember that. So oftentimes, if we think about this being probably somewhere around 70 to 80% of the cases is this. That means very little of it is HSV2, probably VZV. And the last ones are kind of the random ones. Things like probably mumps, maybe even like measles, rubella, things like that. We just don't think about these. Really, you think about this, maybe mumps, they would try to test you on the exam. And the only reason they would do that is you'd have a person who maybe was like under-vaccinated for their MMR. So maybe they had an under-vaccinated status. And this was for their MMR, their measles, mumps, rubella. But the only reason I would say that they would consider mentioning mumps is because this presents with very specific clinical features that kind of like scream it, and they could kind of like maybe let you lead into thinking about that before you get the results of the PCR. And that's if they had like orchitis, so they got a swollen nut in a male, or you got a swollen parotid gland, a parotitis. That's something I would think about, all right? So parotitis or orchitis would make you think potentially about this condition, like measles, mumps, rubella, but primarily mumps. So the reason why I tell you this is that for these, when you have a patient who presents with meningitis, you're going to be treating them with those drugs to cover, well, all of these pathogens if they have the risk factors. Aseptic viral meningitis, you're really only going to consider the acyclovir as an add-on when? If they have particular risk factors. And usually these kinds of conditions don't commonly occur if they're not immunosuppressed. And so this would be something I would maybe consider in an immunosuppressed patient, or if they have these types of risk factors, I may add on the acyclovir. But oftentimes, if it's aseptic viral meningitis, we don't do anything. And so we don't really need a specific treatment for that. All right, what about those rare pathogens? So when we talk about rare pathogens, there's not a lot that I want you to go crazy on here because we're going to talk about these individual pathogens in separate lectures. But for right now, I want you to think about potentially something like TB, right? Maybe cryptococcal meningitis. So TB meningitis, cryptococcal meningitis, maybe Lyme, maybe Rocky Mountain spotted fever. Another one could be neurosyphilis. And then the last one we talked about is, I know I spelled this wrong. And the only reason I know this is because you guys can't see this, but this guy, Rob, he's on the other side of the screen. He looked at me with the beady eyes, all right? So I know I butchered that one. But anyway, we fixed it up. Neurosyphilis, and the last one is the Naegleria. All right, so the Naegleria. And we actually talked about this one a little bit, so we'll kind of maybe breeze past this one because I don't want to bog you guys down with stuff like this that you're probably not going to be tested on too much in this scenario. TB is something that I would think about if the patient had specific history. Maybe they'd have a positive tuberculous skin test. Maybe they have a chest x-ray or a CT scan that shows some weird kind of like calcified nodules in the lungs. Maybe they have HIV co-infections, or they have an HIV, or they have an immigration status, or they were from an endemic area, they were in a prison, something to that effect, right? Cryptococcal meningitis is one that I actually would want you to consider. So TB, I would think about it, but again, we're going to talk about this more when we get into lectures that are talking about tuberculosis. Cryptococcal is one that I want you to consider. And the reason why is they may consider this, we'll talk about this more in the HIV lecture, but AIDS. AIDS with a CD4 count less than 100, you really want to consider a fungus like cryptococcal meningitis. Lyme, again, we see this more particularly with there being a tick exposure, so they're probably somewhere in the northeastern United States. And so with both of these, Lyme and Rocky Mountain spotted fever, I would think about any kind of tick exposure. So tick exposure is a pretty common one, but they may not present that on the exam. What they may present that makes you even think about these is there was some recent travel to these particular areas, northeastern United States, the Rocky Mountains, and then what happens is they present with clinical manifestations that maybe make you consider it. And the only reason I tell you that is because all of these have different treatment methods. We don't treat these with this. We treat this one with like rifampin, isoniazid, pyrazinamide, ethambutol. We treat this with a very specific antifungal, amphotericin B, which is amphoterrible. It really jacks up the kidneys. And we also give something like flucytosine. For this one, we give doxycycline. For this one, we give penicillin. And for this one, we throw the kitchen sink at them and hope that they survive. The whole point is that if you did this, for this, you're not going to get that true coverage of these. And if you added all of this on, you will have so many drug reactions, you won't know what the heck is going on with your patient. So that's why we only think about these if they have very specific risk factors. So for here, they'll probably say on the exam, a bilateral facial nerve palsy. And maybe a radiculopathy. That can kind of scream of Lyme. And if they had the erythema migrans rash present somewhere in there, makes you think about it. But the more particular one is this maculopapular rash. And usually it's on the hands, the wrists, and sometimes the trunk. And it's very characteristic rash that makes you think about this one. Neurosyphilis, obviously if they had a sexual history, HIV is another common risk factor for this one as well. But there's probably two things that'll make you think about it and scream it out loud. And that is usually if they present with something called tabes dorsalis. And it's kind of within the name, but it affects your dorsal white column. So tabes dorsalis is it can damage the dorsal white column. And so what does the dorsal white column control? proprioception, vibration, fine discriminative touch. And so if you have damage to that, you're going to lose some of those potential sensations. So they may have some ataxia, they may have difficulty with particularly their fine and discriminative touch, maybe their proprioceptive kind of understandings, their vibration. So that's something to think about. And the other one is called an Argyll-Robertson pupil. And the only reason they would kind of mention that one is that neurosyphilis has a very high affinity for the the pretectal nucleus, which is in the midbrain, the posterior midbrain. And so when it hits that, that controls your third nerve, the Edinger-Westphal nucleus, which controls your pupil kind of response. And so what would happen is you would kind of do their pupil response and you would notice that they would not have their constrictive response to light because you're nailing the pretectal nucleus, which then you can't send signals to the third nerve to allow for that pupillary light reflex. So they lose that. But then if you have them follow their finger inwards, they can accommodate. And so they have that type of process, which we can kind of sometimes call like a light near disassociation. And that's an Argyll-Robertson pupil. All right, that would scream a neurosyphilis. Right? Naegleria is that water rushing through the nose from a freshwater source. TB, again, with this one, they're probably going to present some type of history like any endemic history, so probably some type of immigration from a particular area. And then the other thing is other risk factors. They may have HIV. That's another really positive one. And then the other thing is to think about like maybe a positive TB test. So maybe a positive TB test or their chest x-ray. They have an abnormal, so they have some type of like positive chest x-ray for like maybe like a nodule of some sort. These may make you think and consider something like tuberculosis, all right? But again, the only reason I'm mentioning these is because these have very specific therapeutics that we target. We won't cover them with these. You're only going to think about these in the proper clinical scenario. So to kind of recap meningitis, when a patient comes in with meningitis, it's either this or this usually. Rarely is it this. You're going to cover them with these antibiotics. Rarely will you need to add on acyclovir unless it's this. And then again, with these patients, if they have these particular risk factors, you can consider adding these, but oftentimes you're going to add on the specific tests. I'm going to check for a serology and I'll do a CSF antibody test for these. I'll check my FTA, I'll check the VDRL. For this one, I'll check the mycobacterium culture and the acid-fast bacillus. For this one, I'll check the cryptococcal antigen. You get the point. I'll send the specific test to identify it and then treat accordingly. All right. Let's move on now. Let's talk about the other etiologies. All right, so let's move on to the next thing, which is encephalitis. So we talked about meningitis. The really important one to remember is the acute bacterial meningitis. With encephalitis, this one is actually due to a couple different kinds of viruses that you really want to consider. And so what are some of these? I think the most important ones to really consider is going to be, again, your HSV. But this is usually going to be HSV1 or some type of varicella zoster virus, right? Now, with these, it is really, really important to remember something kind of nasty about encephalitis. Encephalitis is inflammation of the actual brain parenchyma. But there's, oh wow, that's loud. There's very specific lobes that tend to be affected. And I really want to kind of go ham on this one. When a patient has headache and fever and maybe they have some meningeal signs, that could suggest meningitis. But you can have patients who have encephalitis, and sometimes if they have a little meningeal irritation, they can also have meningeal signs. And so that's why sometimes when a patient comes in with a fever, a headache, maybe an altered mentation or personality, cognitive behavioral changes, we have to have a high degree of suspicion of encephalitis. And the reason why is encephalitis especially, this is going to be the one that I need you to remember here. So HSV1, actually, just for simplicity's sake, I'm gonna put VZV down here. Just to be more specific, I'm gonna put VZV right here. HSV1 is going to be really, really important. And there's a couple things I want you to think about this one. With HSV1, the most common location of encephalitis, so this is first off, it's the most common. So it's the most common, so let's actually write that down. It's the most common cause of encephalitis. And the second thing is the area of the brain that it has a predilection for. Do you guys know? The temporal lobes. The temporal lobes. I know you guys were screaming that out through the camera. The temporal lobe, baby. So this is going to be a very, very particular thing. And the reason why is oftentimes this will cause maybe a bilateral asymmetric temporal lobe inflammation. And sometimes it can even be hemorrhagic. This stuff can be really, really nasty. So HSV1 is really, really, really important. And the reason why it's really important is that this is the one that, since it's the most common, and oftentimes with encephalitis, it'll present with altered mentation, seizures, personality, cognitive behavioral changes. So they have memory, they're irritable, they're restless, they're not their normal self. That's the ones that we want to add on acyclovir. So acyclovir would cover this kind of consideration if there was varicella zoster virus or HSV2 causing aseptic meningitis. But what's the most common one? It's most often going to be the echoviruses or the Coxsackie virus. For this one, the most common is HSV1. And the reason why this is important because this carries a super high risk of mortality if you don't treat encephalitis properly, especially HSV1. So this one we treat with acyclovir. So again, it's really, really important to remember that HSV encephalitis carries a very high risk of mortality. That's extremely important. Now, if a patient does have VZV, guess what? You can do the same thing. You can treat them with acyclovir, right? So that is something definitely to consider. But another one that I think that sometimes they can try to test you on for the exam is certain types of arboviruses. And these are usually spread by certain types of insects, especially things like mosquitoes. And there's one particular one that I think that they may try to get you on with the exam every now and then, and this is called the West Nile virus. Now, the important thing here is that if you have West Nile, you're not going to treat them with anything specific. It's just important because they may ask you what is the most likely pathogen. And the reason why this is important is with West Nile virus, this also tends to cause an acute flaccid paralysis. So this tends to cause myelitis as well. So you may see the patients exhibiting what's called acute flaccid paralysis. That thing's limp, right? So acute flaccid paralysis. That's the important thing to remember. So if you hear acute flaccid paralysis and encephalitis symptoms, in other words, they're presenting with fever, headache, altered mentation, seizures, cognitive behavioral changes, and the acute flaccid paralysis with some type of recent travel to the areas that this is a high-risk disease, and they've had those mosquitoes that are nearby, that could be the potential etiology. But either way, the important one that really, really matters is HSV1. Because if you don't treat HSV1 encephalitis, the patient has a super, I'm talking like untreated, I think it's like 55 to 70% chance of mortality if you don't treat it. So that's why it's really, really important to remember. All right? Now, really quickly, it is possible to have both of these. So you can have meningitis and you can have encephalitis. So all that is, let's say that a patient has some type of encephalitis here, and then they develop some kind of associated inflammation of the meninges, or the pathogen infects both of them. That is an important terminology to understand. A lot of the time there is a significant degree of overlap. So this is called meningoencephalitis. And this is very common. I'm not kidding. A lot of pathogens tend to cause both. So this is extremely common. So that's why sometimes when we think about these patients who come in with fever and headaches, right? And maybe some photophobia and maybe phonophobia, it's really important to then start kind of thinking about what really screams the encephalitis picture. And we'll get into that. That's usually those altered mentation, seizures, cognitive behavioral changes, aphasia, focal deficits. That screams more of an encephalitis than it does scream more of a meningitis type of picture. But oftentimes, they can have a degree of overlap. And this is pretty common with viruses. This is pretty common even in pathogens like bacterial meningitis as well, where you can get this kind of degree of overlap. All right, so that's the last thing I wanted to finish with the meningitis and encephalitis is that you can have a degree of overlap. The last CNS infection that I want to talk about etiologies with is brain abscess. So we think about this. Patient comes in, fever, headache, and then you start thinking, okay, could they have meningitis? Could they have encephalitis? We'll talk about the clinical signs. You say, all right, I think that they could have meningitis. They could have encephalitis. I don't really know. I got to get an LP. I'll get my blood cultures right now. I'll prepare for the LP. I'll get my LP and I'll start them on these therapies. And I'll start them on things to cover the bacteria. And if they have any focal neural deficits, if they have any seizures, altered mentation, and I have a thought, any kind of like small thought that they could have HSV encephalitis, I got to add on acyclovir. What about brain abscesses? Brain abscesses, again, they can present with headache, fevers. Fever doesn't have to always be there, but the headache is usually the case, and it's not usually sudden onset, it's progressive. But the focal neural deficits is what's really key. So that's when I like to think about this. Let's say that we get a CT scan because a patient has focal neural deficits. I've got to be concerned, do they have a stroke or a bleed, right? I want to know if it's a pyogenic looking abscess or a non-pyogenic. Does it have a purulent material in it or not? So pyogenic ones. Usually with these, there's a couple ways I want you guys to think about this again. So a pyogenic is usually, it starts off with some type of cerebritis. Then that cerebritis has a liquefactive necrosis. And then eventually, that liquefactive necrosis, so you have early cerebritis, late cerebritis, and then an abscess. And this guy's throwing markers in the air. And then we'll kind of do this. So you start off with early cerebritis, then you start causing liquefactive necrosis, late cerebritis, and then a brain abscess. So there's a purulent material there, where this one, maybe it doesn't actually have some type of purulent material. There's no pus. Maybe there is some type of pathogen in there, or maybe there's a parasite in there, or maybe there's other kinds of things like fungus in there, but it's no purulent material. That's what we call non-pyogenic. Pyogenic is pretty scary, and these are the ones that we're going to treat with very specific antibiotics. Non-pyogenic, we have specific therapies for that we'll kind of talk about. But this is the one that you're probably going to have most of the time considering. I'd say you'd probably be lucky enough to say this is 90% of the cases, and that's going to be the other like small 10% of cases. All right? With pyogenic, the next thing I want to say is, let's say I get the CT scan, right? And I see this kind of like, I see this ring-enhancing lesion, and that's what you'll have in both of these, a ring-enhancing kind of lesion. I want to know, does it look like it's purulent? Usually that's where I can kind of get into what's called MRIs. So for right now, I just want you to trust me. I want you to trust me that if it's a pyogenic one, it's usually going to have some type of positive MRI finding, all right? We will go over this in the diagnostic section, but for right now, just trust me. And the non-pyogenics are not going to have a very specific MRI finding. From there, I want to know, how many abscesses do I have? Do I have one or multiple? This is not always perfect, but it's pretty darn close and at least good enough for your exam. That if you have a solitary abscess, it's important to know where it's at, right? This goes back to talking about routes. If I say that I have an abscess, a solitary abscess, and it's located at the frontal lobe, or I have an abscess and it's located around the temporal lobes, then what am I thinking about? I'm thinking about very specific kinds of sources. So for example, if I said I had a frontal lobe abscess, which types of sources would I be kind of thinking about? Come on, scream it out, guys. Yell it. I'm thinking about my sinusitis and my dental, right? Dental infections. So this is usually going to be your frontal, ethmoid. We got to make some room here. Frontal, ethmoid, and maybe we can squeeze this in here. Your sphenoid sinusitis. And then what's the other one that we're thinking about? The dental infections, right? So periodontal disease of some sort. So then I'm thinking about dental infections. This can be covered with the same antibiotics unless it's maybe from this next step over here. So here we're going to say this is a frontal lobe abscess right here. Then we're going to say this could be a temporal lobe abscess. And sometimes these are going to occur in the cerebellum as well. So let's say here we have a temporal lobe abscess. Where then would you want to start investigating a little bit further on the MRI or the CT scan? So I want to look here at the ethmoid sinuses, frontal sinuses, and I want to look at the teeth. For the temporal lobe, I'm going to want to take a look where? At the middle ear, and I'm going to want to take a look at the mastoid sinus on the CT scan. So I want to get some temporal facial bone kind of like in windows. So I'm going to want to look at the mastoid sinus. I want to look for some mastoiditis. And I also want to look for any kind of evidence of acute otitis media, or AOM. This is why it's important, because at these levels, it guides what type of antibiotic you most likely can stick with. A lot of the times with empiric brain abscesses, we oftentimes will start them on things like vancomycin, ceftriaxone, and metronidazole, because it's going to cover any kind of strep species, staph species, and also any kind of anaerobe. But if we have a pretty good inclination of what's the most likely etiology, especially if it's from frontal lobe or temporal lobe abscesses from these, you probably don't need that vancomycin coverage. You could probably get away with ceftriaxone and metronidazole. If they have the acute otitis media with some chronic ear disease, you may want to consider things like Pseudomonas and maybe bump it up to cefepime. But either way, I could probably get away with metronidazole, and I could probably get away with ceftriaxone to cover most of these infections, and maybe for that chronic ear, diabetic, HIV infection where the Pseudomonas becomes a risk for acute otitis media, I would consider, instead of ceftriaxone, I'd consider things something like cefepime. But that's the reason why I want you to think about these. These are pyogenic abscesses that are location specific that may point to the underlying etiology and source, which then may narrow down your antibiotics. Whereas, if I also think about another location, what's another location for these? Another location that I want to be concerned about is the cerebellum. So cerebellum is another one as well. So you definitely can get these as well, and usually when it's the cerebellum as the potential source, so a cerebellar abscess. So we'll put here cerebellar abscess. Guess where you want to be looking? It's the same kind of concept. I'd want to be looking at these. So again, I want to be looking at some kind of issue here. Let me take a look at their middle ear. Let me take a look at that mastoid sinus and see if there's anything going on there. But this is the concept I want you to think about. If it's solitary, think about these particular etiologies. If it's multiple, okay, then it kind of gets a little bit more challenging. With multiple, what I want to know is, where is the location in general to the gray-white junction? If I see abscess here, if I see abscess here, if I see abscess here, and they're along that gray-white junction, this almost likely screams to me hematogenic seeding. This here screams contiguous spread from a nearby source, right? This screams hematogenous because it got access to the cerebral circulation. So if I accessed my MCA, if I accessed the PCA, if I accessed the ACA, I could spread these infected material to multiple vascular territories. Do you get what I'm saying? So that's where it's important to remember, is if I see multiple abscesses along that gray-white junction, that watershed area, that is what screams to me potentially from a hematogenous source. So these are usually going to be along that gray-white junction. So along gray-white junction. And the other important thing is that they may be involving multiple vascular territories. So, okay, multiple vascular territories. And that, more than anything, screams a hematogenous source. And that's important because what are the two main hematogenous sources that I talked to you about? Yes, it could have come from the nasopharyngeal mucosa, yes. What was the most common thing for the nasopharyngeal mucosa? What was the particular pathogens that we got worried about that caused which CNS infection? It's usually strep pneumo, Haemophilus influenza, Neisseria, they cause meningitis. It's not as common for those to get in and cause something like multiple brain abscesses. Usually with these, we get worried about two particular things. I get worried most often about things like infective endocarditis. And the reason why this is important is with infective endocarditis, I actually have to go and figure this out. So afterwards, I got to do with this, usually the CT scan, the MRI can give me an idea if one of these kinds of areas are infected or inflamed. And I can do a good physical exam. I can take probably something you don't use a lot, right? I use my otoscope, take a look. I'm going to look up through the nose. I'm going to look in the mouth. I'm going to see if I can find any kind of lesions and do a good ENT and dental exam. For infective endocarditis, I'd have to do an echo. And I'd have to have my blood cultures to tell me what kind of pathogens in the blood. Another one is something like pneumonia or really nasty lung abscess. And the reason why I'm telling you about these as the potential source of flinging off these pathogens into the bloodstream, causing hematogenous spread, and that then leading to all of these infections that you kind of see here, ba-bop, 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 is the type of pathogen associated with this one. We already talked about these. It's usually going to be Streptococcus viridans, maybe also what else? Your anaerobes. So with the solitary ones, I want you to oftentimes associate these with two things, Streptococcus viridans, which there's different types of groups, but Streptococcus anguinus is usually going to be one. And then the other one is going to be your anaerobes. And usually their most important one here is going to be Bacteroides fragilis. And if you have these, you can get away with ceftriaxone and metronidazole. You may need to add on, again, either swap out the ceftriaxone for cefepime or meropenem if you got that Pseudomonas for the acute otitis media. But with multiple, I got to worry about specific things. The most important one is I want to worry about Staphylococcus aureus, right, for MRSA. MRSA for this particular thing. That's what I definitely get concerned about. And another one is Streptococcus viridans. For pneumonia, I want to worry about things like Streptococcus pneumonia. But I also want to consider a really nasty one. You guys know what that one would be? The really scary one that you want to consider is something called nocardia. And again, we're kind of tying these together back to the stuff that we talked about before. So this is the things I want you to think about, because the reason why this is important is in patients who have multiple brain abscesses, I want to be able to cover things like Streptococcus viridans and Staphylococcus aureus. So I could probably get away with something like vancomycin and probably ceftriaxone. Same thing for this one. I could probably get away with vancomycin and ceftriaxone. If it's nocardia, that's a little bit different. We'll talk about that later in the treatment section, but this is really going to be in those immunosuppressed patients. I'll have to have very specific clinical guidelines that make me determine this one. It's a little bit more challenging. But oftentimes with a hematogenous source, you can probably get away with something like vancomycin, and you can probably get away with something like ceftriaxone, because you're covering those species. This is why you have to tie the etiology, the specific pathogen, to the antibiotic choice of that regimen. Now let's take a second and say, okay, brain abscess, they're presenting with specific symptoms. I get an MRI, it shows findings that scream more pyogenic. I need to know, is it this? Whereas if it's multiple lesions, the ones I want to think about more often than not is going to be Streptococcus viridans for sure skis. But I also want to think about, no, I put the period there, I want to think about Staphylococcus aureus. And that's that MRSA one. Every now and then, if we have the specific risk factor, and we will talk about this, I promise, more in the treatment section, nocardia, usually immunosuppressed people. All right, usually immunosuppressed people. We'll talk about a very specific diagnostic test that screams this one. But most often, this is going to be the case. So you can put this patient on, again, what kind of therapies? Usually ceftriaxone, metronidazole. Sometimes you may have to consider switching up the ceftriaxone for cefepime if they have Pseudomonas. This one, vancomycin, ceftriaxone, and I'm pretty much good. If you have not a clue of where this could be, you can put them on ceftriaxone, vancomycin, and metronidazole, and it covers everything. All right? Let's say you have the non-pyogenic source. In other words, there's no specific MRI findings, which I promise, I'm gonna tell you guys about. It's looking at the DWI and the ADC sequence. But these don't really scream that pyogenic source. Maybe they also don't have any kind of features that screams it from a hematogenous or contiguous spread as well. With these, there's a couple, all right, that I would want you guys to consider. With these, the first one I want you to think about is toxoplasmosis. So toxoplasmosis. This is a nasty one, all right? So it's a weird type of parasite that usually you can get. And those patients who are usually pregnant are very susceptible, but a really susceptible population, we kind of almost call this like an AIDS-defining illness, is those patients with AIDS. So if a patient has AIDS and they have a CD4 count, AIDS with a CD4 count less than 100, you really want this to be on your actual kind of radar. There's specific locations that scream toxo. So what toxo really makes me want to think about here, so I'm going to put toxo here, is let's say that I have this kind of what appears like a ring-enhancing lesion. It looks like a brain abscess. And actually I want to be very specific. I want to put it where it often most occurs. So here in the deep subcortical area, we'll have a structure called the basal ganglia. That's oftentimes where you'll see these. Usually you're going to see these most often where? In the basal ganglia. So toxoplasmosis oftentimes occurs where? In the basal ganglia. So let's write that down. If you see multiple lesions in the basal ganglia and they have AIDS, CD4 counts less than 100, or you don't even have that, but you suspect it, you want to definitely consider, could this be toxoplasmosis? And in those scenarios, you would have to send off a serological study like a Toxoplasma gondii IgG antibody, and then you may have to put them on a specific therapy. This is why it's important to think about these, because guess what? I'm not going to put everybody who has a brain lesion on kind of stuff for toxoplasmosis, because that's a lot of medications. They get 3 different meds, right? I need to have specific risk factors and specific findings that make me think one over the other. All right, the next one is called neurocysteric. Oh man, I'm so bad at spelling. This is called neurocystericosis, right? This one is actually due to, so you want to think about this, I'd say most likely as a person who traveled, and it's in endemic areas. So probably the things I would think about is like, were they in Africa or South America? And I'm not kidding, were they trying like weird types of foods? Usually like a pork kind of related meal. That can contain a tapeworm. And that tapeworm is called Taenia solium, all right? Now, Taenia solium is a nasty little son of a gun. And when this thing gets into the bloodstream, so it's actually due to a parasite. And again, this one is going to be Taenia solium. This here is actually going to get into the bloodstream. It works its way up into the brain tissue. And this is a really, really unfortunate one. It can produce, I'm not kidding, sometimes you can have a couple, sometimes you can have hundreds of these little, what look like cysts all over the brain. And what we see with this condition, with the neurocystericosis, is you're going to see these lesions, but what you're going to notice, and again, we'll get into this more into the diagnostics, is you're going to see the mouth. It's called, so they have the scolex, the little portion that they latch onto tissue. This is called a hole in dot sign, the hole in dot sign. And the hole in dot sign really signals to you potentially neurocystericosis, especially if they had some type of recent travel, they were sampling foods from areas of Africa, South America. I would definitely be thinking about this kind of condition, right? So what do we call this again? It's called a hole in dot sign. That is usually somewhat pathognomonic, screaming something like neurocystericosis, all right? The last ones I'm not going to go super crazy about, but I want you to think about any kind of fungal kind of pathogen. So any kind of fungal pathogen, you really want to think about these. I'm not going to go through all of them, but usually it's going to be things like aspergillus. Actually, I should mention one. One of them that I do think is really worth mentioning because they may try to test you on it is called mucormycosis. So let's actually write this one down. It's called mucormycosis. So this is a nasty fungal pathogen, and it's usually due to like a rhizopus kind of species, mucoralis. And with this one, usually what happens is these patients, they usually oftentimes present with a couple different symptoms. One is they can have sinusitis. So they oftentimes have a pretty nasty sinusitis. And then another thing with this is that with these infections, they can spread to the bone, so they can get orbital involvement, and they can spread to the brain. And so you may get these patients with abscesses, these kind of like non-pyogenic kind of lesions here, and they can get orbital lesions as well. But here's the nasty thing, is that sometimes with this, they have this chronic sinusitis, it can literally become necrotic tissue, and it can produce things called eschars. So when I want you to think about mucormycosis, is a patient who probably has some type of, I'd say oftentimes, yeah, probably most often they're going to present this on an exam with a patient who has diabetic ketoacidosis. So some type of DKA patient, maybe a neutropenic patient. They're going to have chronic sinusitis. They may have some chronic orbital pain, but the big thing that's also associated with this is these necrotic eschars that they have, usually over the sinuses and the face. That is going to scream something in the range of mucormycosis, all right? And these can cause potentially these non-pyogenic brain lesions as well. So here, taking away from the etiologies here, the big things to remember, acute bacterial meningitis, I want you to think about strep pneumo. I want you to think about Neisseria. I want you to think about Haemophilus influenza and Listeria. That's going to give you your empiric coverage, right? With that add-on of ampicillin for listeria. Then you think about hospital-acquired scenarios and only those select cases, because that guides whether or not you add on a pseudomonal coverage. The only time you worry about the antiviral acyclovir is in primarily the situation if it's HSV-1 encephalitis. That's going to present with very specific clinical signs and symptoms, all right? But you have to get that one on there because they have a high rate of mortality if you don't. For the brain abscess, you want to know, does it suggest a pyogenic or non-pyogenic? If it's pyogenic, you want to know, okay, is it solitary one? So is it in one location, frontal lobe, temporal lobe, cerebellar lobe? I may have the source on the image and I can kind of treat my specific antibiotics appropriately to cover those. If it's multiple, then you're thinking about more of a hematogenous site. And I got to go looking for that hematogenous site. I probably have to get a CT scan of the chest, abdomen, pelvis. I'll probably have to do an echo and blood cultures and figure out where this is coming from. But at least until then, I can cover where I think it is. And then for those non-pyogenic sources, we're thinking about the rarities, but I'd say out of all of these, the one that I really want you to consider is going to be that toxoplasmosis. Because that's the one that they may present again with these ring-enhancing lesions in the basal ganglia, that AIDS patient, and that's when you're going to want to know that one. Send off some specific serology studies and start them empirically on specific therapies. All right, at this point, we've built a pretty good foundation, I think, on the etiologies, the risk factors, the pathogenesis behind meningitis and encephalitis and brain abscesses. Now what I want to do is I want to talk about how does that actually present clinically so that we can think about that. And then worst case scenario, what if these patients don't present with fever and headache and meningeal or cortical signs, but they present with very specific complications? I should be able to identify that. And also, if I diagnose them with this condition, I need to know what kind of course do they have that I need to watch out for. All right, my friends, so now we're going to move on to the clinical findings, especially those things that are classically representative of CNS infection. So when I have a patient who comes in, oftentimes it is really important to know that they will have kind of a similar presentation. It may be different slightly in the onset or the aggressive nature of the symptoms, but for the most part, if I see a patient coming in with some type of fever and headache, I want to start thinking about some type of intracranial process that could be going on, right? That's the first thing. The next thing that I want to add on that maybe adds some specificity to meningitis or encephalitis or to brain abscesses can come with this component here. So let's say here down on this side, we're going to have meningitis, encephalitis, and the brain abscess, and then we have meningeal signs and cortical signs. For the most part, in pure meningitis, they will have the presence of positive meningeal signs. And for the most part, as long as it's pure meningitis, they should not have any cortical signs. For encephalitis and brain abscess, they shouldn't really have any meningeal signs, but they should have some type of cortical sign potentially present. All right, so all of them can present with fever, all of them can present with headache. Usually, for meningitis, it's a very severe acute onset, especially if it's acute bacterial, fever, headache. This one definitely can have a fever. More likely the headache is concerning, but we're really going to talk about the cortical signs and why that's important. Brain abscess, it's more of a progressive headache. They don't have to have a fever, but they will have some very concerning cortical signs. We know that meningitis can have fever, headache, and meningeal signs. And so sometimes we actually call this meningismus. And there's very specific things that can help you to think about this. Now, the problem is that, when we think about meningeal signs, usually what happens is when you have meningitis, it changes the degree of the stiffness and the rigidity of the neck. And so we can call this, I preferably like to call it nuchal rigidity. And so that's generally there is this stiffness of the neck that's really, it's hard with neck flexion, right? And so it usually can precipitate a lot of pain with some type of degree of neck flexion. So they're oftentimes going to have a degree of neck stiffness and some difficulty and rigidity whenever they actually want to flex the neck. And so we call that nuchal rigidity. So that's one of the potential meningeal signs, right? So definitely think about this. Again, this is the back of the head of the patient. This is Rob. He's definitely got that kind of like bald spot there going on. But this right here is going to be the thing I want you to think about, is some type of like stiffness of the neck. That's usually going to be a result here of the actual meningeal inflammation, and it's going to be really, really difficult for them to be able to flex their neck. So a lot of pain there and stiffness. The other thing that we also can consider is specific tests. The problem is that these tests that I'm going to tell you about do not exclude meningitis if they're negative. There is one that is actually, during the research I found, actually it did have like a pretty good sensitivity. We'll mention that one as well. But these are two tests that you always are going to see on the exam. So one of them is called the Brudzinski's. So it's called the Brudzinski sign. And the other one is called the Koenig sign. Now, if they have a positive Brudzinski sign and a positive Koenig sign, it does bring about the suggestion of meningismus or the potential for meningeal signs, which does potentially suggest meningitis. The problem with these two is if you have a negative Brudzinski, so if there's a negative, I just want you guys to really, really understand why this is important. A negative Brudzinski and Koenig does not exclude meningitis. These are literally probably only about 5% sensitive. So that's not a great test at ruling out things. It may help you to rule in this consideration. With Brudzinski sign, all you're trying to do is you're going to have the patient lay flat on their back and you're going to gently bend their neck or flex their neck. So that's what you're going to do. You're going to lay down and you're going to try to gently kind of bend or flex the neck. When you do that, this will precipitate pain and a response of their actual knees and hips. They're going to want to flex their hips and they're going to want to flex their knees. And so the way I like to think about this is a couple of different things. Whenever you bend the neck, so bend the neck, this will produce pain, but it also will precipitate hip and knee flexion. All right, so hip flexion and knee flexion. So again, essentially what you're doing is you're bending the patient's neck. As you do that, it'll precipitate pain. And one of the responses to that is that they will flex their hips and flex their knees. Here's a short little video clip to kind of show you what that is.
To test for the Brudzinski sign, place a hand behind the neck and gently flex the patient's head toward the chest. A positive exam is marked by involuntary flexion of the hips and knees, as you see here.
With a positive Koenig sign, what you want to think about here is that they're still laying flat, but then what you're going to do is you're going to get their hips and you're going to get their hips flexed to about 90 degrees. And then what you're going to try and do is you're going to try to extend the knee out completely, but it's actually going to be really difficult to do that. So what's going to happen is you're going to try and extend out this knee, but that process is going to be really difficult to do. It's going to precipitate a lot of pain. So that's usually the key thing, is that this will precipitate a degree of pain, and there'll be the inability to be able to fully extend the knee. So pain and inability to extend the knee. All right? So again, knee extension is becoming the difficult aspect in the Koenig sign, and whenever you bend their neck, it causes hip and knee flexion as a result, and pain in both of these situations. Now, again, the negative aspect of this test, if they don't precipitate these findings, it doesn't necessarily exclude meningitis.
With the patient lying flat, bring the hip and knee to 90 degrees. Support the knee and ankle. Now gently extend the knee. Stop when you feel resistance or the patient reports pain in the hamstrings or lower back.
What I will say is there is another test that is, I'd say, almost about 100% sensitive. And so the other one that I would want you to consider is you can actually have the patient on their own go ahead and rotate their head from left to right. And do this a couple times, all right? So you're gonna have them go left, right, left, right, left, right, left, right. It's called the jolt accentuation maneuver. If this worsens their headache, that pain that they have, that could be concerning. And again, it's about 100% sensitive for meningitis. So again, you could look for something called a jolt accentuation maneuver. So it's called a positive jolt accentuation maneuver. And all you're having them do is essentially just rotate their head at least 2 to 3 times per second from left to right. And if it worsens their headache or it precipitates a worsening of their headache, so again, we'll say with this rotation, they get an increase in their headache, that is a positive sign. And that could be indicative of meningitis. And again, if this is positive, It's about 100% sensitive. So if it's negative, you can at least with pretty good degree of certainty say it's unlikely meningitis. And so this one I think is an important one to remember because it does have approximately somewhere around 100% sensitivity. So approximately 100% sensitivity. These ones might be about 5% sensitive, and so that's why they're not great tests. But for the exam, you're gonna see these. You're probably not gonna see this one. So okay, meningitis will have fever, headache, and they can have some meningeal signs, nuchal rigidity, positive Brzezinski's, positive Koenig's, or a positive jolt accentuation maneuver. Can they have cortical signs? They can. It's just not something that I want you guys to think about right away. And so with cortical signs, I want you to associate this more with brain abscesses and encephalitis, but you can see this with meningitis. So meningeal signs, this screams which one? This is going to scream more of that patient who has meningitis. All right, it's going to scream more likely than not meningitis. All right. Whereas the patient who has cortical signs, this could scream any of them. Right? It's just more often than not that you want to think about this one with encephalitis and brain abscess. So I want you to think about this more with encephalitis and a brain abscess. And the reason why this is important is because if you think about patients who experience encephalitis, it's inflammation of the brain parenchyma, right? And which is the most common location for what's called HSV1 encephalitis? I told you that if there is any particular type of encephalitis, this is the one to remember. And what is the most common location that is affected or inflicted by this condition? It is the temporal lobe. So this whole area here is under fire. This area here is potentially getting just completely gaslit, right? You then want to think about what are the potential things that could manifest in that scenario. Well, think about this. In the temporal lobe, all right, you're going to have structures like, for example, the hippocampus. So if the hippocampus is affected, what could you potentially have? You could have some degree of memory impairment that could be potentially visible in these patients. So memory impairment is something I would consider. The other one is the amygdala, or any kind of like limbic nuclei. So hippocampus technically is a limbic nuclei, but let's really like dig deep into this and say, let's think more particularly things like the amygdala. This is going to cause behavioral changes. So if you see some type of cognitive behavioral changes, this really should make you think potentially about HSV encephalitis. The other thing is that this is where speech is controlled, right? So this is going to be important for speech because there's very close areas nearby. So you have your Wernicke's area, and then you have the arcuofasciculus that's actually going to be between these two as well. So this is going to be very, very critical for a lot of speech. So you're going to have association fibers in your speech centers there. So speech and understanding. So I'd say speech and a lot of the aspects of speech is really important. And so let's say in this scenario, what could you potentially experience? These patients may have aphasia. And so that is another potential thing that I would want to watch out for. So a patient who experiences things like aphasia, memory impairment, cognitive behavioral therapy changes, or cognitive behavioral changes, makes me really want to think about something going on with the temporal lobe. So some type of, again, temporal lobe involvement may scream this potential picture here, all right? So if I had a patient who came in, they had headache, they had fever, they have cognitive changes, so they have a lot of memory impairment, they have behavioral changes, so they're having psychiatric changes that are inappropriate, or they're having difficulty with their speech, I then can't fully rule out encephalitis. Another really important thing, and we'll talk about it over there, but this carries a very, very, very high risk of seizures. And so that's another one. We will talk about it more, but it is very high risk for seizures. And so these patients have a very high incidence of seizures. So that's what I want you to think about for HSV encephalitis. All right, so we're talking about here, meningitis, we're most likely focusing on acute bacterial meningitis. Here, when we talk about encephalitis, we're most likely talking about HSV1 encephalitis. All right, the next thing I want you to think about. With brain abscesses, they can experience a lot of focal neural deficits. And those focal neural deficits depends upon where the abscess is actually occurring. So for example, if I have an abscess that's occurring here in the frontal parietal lobe, or if I have an abscess that's occurring here in the cerebellum, or if I have an abscess occurring here in the, let's say in the brainstem, or here in the temporal lobe, depending upon that location, obviously, you're going to have mass effect. And on top of that, you may have destruction of the neurons in this area because of the infective process. And so just think about that. I think the biggest thing is think about mass effect, and then also the destruction of the appropriate neurons. But if I have nearby structures that I'm compressing down or I'm losing function of, you can make sense of it, of what they kind of, what kind of focal deficits they may experience. So for example, if I were to write out here some focal deficits, well actually let's write this out. Let's say brain abscess is the really big thing that we're thinking about here. What are some concerning features that may scream this over HSV1 encephalitis or meningitis? Well, the big thing here is, if I think about these focal deficits, let's say that I had one in like that frontal parietal lobe. What would be a concerning feature here? I would definitely be concerned about maybe some type of hemiparesis. So maybe they would have some type of weakness or paralysis of the affected limb on the contralateral side. If I had it affecting the temporal lobe, well, what kind of things could be happening with the temporal lobe? Again, I could experience aphasia. I could experience a lot of these potential activities as well, but I think aphasia is a really, really important one. Let's say that I have this occurring in the brainstem. What kind of problems would happen if I have it occurring in the brainstem? Well, what's really, really important that's in the brainstem? Cranial nerves. So cranial nerves could be affected. So they could exhibit potentially cranial nerve palsies. And then lastly, if it's in the brainstem, in the cerebellum, we could experience ataxia, maybe vertigo. And so those are other important features to also consider, is potentially something like ataxia, vertigo. So these are going to be potentially some focal neural deficits that's dependent upon where the actual brain abscess is. And so if I were to kind of just like maybe coordinate these, this is 1, right? 2, 3, 4. So 1, 2, 3, 4. So that's what I want you to take away from this. When we talk about a patient experiencing some types of symptoms of meningitis, we think about fever, headache, and we think about meningismus. Do they have nuchal rigidity? Do they have a jolt accentuation maneuver? Do they have a positive Brzezinski's? Do they have a positive Koenig sign? If that's the case, that could suggest more of a meningitis picture. For those who experience fever, headache, and they have cognitive behavioral changes, so they have memory impairment, they have new kind of onset irritability, anxiety, maybe kind of like personality shifts and changes, they have increased incidence of seizures, or they have aphasia that's new onset, think about HSV1 encephalitis. And if the patient has more of a progressive headache, maybe they have a fever, but they have new onset focal deficits, depending upon where that abscess is, may be explaining their underlying symptomatology. So this is the big thing I want you to think about with these patients is, again, meningitis, fever, headache, meningeal signs. For those with encephalitis, it's fever, headache, and usually these specific cortical signs here. And then another thing I want you guys to also associate with cortical signs is one other thing. Usually with cortical signs is not just the effect of these, but also altered mental status. Altered mentation really screams more of a cortical involvement, some type of involvement of the higher level cortex, or maybe even the reticular formation. So don't forget that. A lot of these patients who have encephalitis and brain abscess can also present with altered mentation. All right, now that we've discussed the classic findings, let's now move into the potential complications that we can see associated with each individual CNS infection. All right, so now let's move on to the complications. Meningitis. We know that this is a patient who comes in, we get concerned about fever, we get concerned about headache, we get concerned about nuchal rigidity, maybe the positive Brzezinski, the Koenigs, the jolt accentuation maneuver. Those are the things that are going to scream more of that meningitis picture. Now, it is important to remember, meningitis can cause cortical signs. It can cause altered mental status. It can cause focal deficits. It's just less common. So what I want you to also associate with meningitis is a couple other potential clinical complications. When I think about meningitis, and it's, again, inflammation of the meninges, right? There's a couple other things that you want to really, really associate this one with. So pneumococcal meningitis carries a really high risk of sensory neural deafness. So what happens is, and I don't want to go too crazy, but the infection that occurs in the meninges, it usually also infects the CSF. And the CSF can be continuous with the cochlear duct, which is inside of the actual what? The inner ear. And so this can lead to potentially damage to the cochlea. So there could be damage, so cochlea damage. So what can happen is some of the infected material that's actually inside of the CSF can spread to the cochlea and lead to a cytokine response and an inflammatory reaction that can cause damage to the respective cochlea. So they can have damage to their cochlear area, and that hair cells could die. And if the hair cells die, you could lose the function, again, whenever those fluid-filled movements occur, that it affects the actual normal depolarization of the vestibulocochlear nerve. The other thing is that there could be damage of the respective nerve itself. What is this nerve that carries information from the actual cochlea? This is going to be the cranial nerve 8, which is the vestibulocochlear nerve. So there could be damage of the vestibulocochlear nerve. And if there is damage of the vestibulocochlear nerve, even if you have the hair cells responding to these fluid-filled movements, they're still not going to be able to send the signal down the vestibulocochlear nerve to your actual medulla and pons junction. And so then you're going to lose that signal, which controls a lot of your hearing. So usually with sensory neural deafness, there is going to be, thus the term, deafness. But there also can be associated features with this, things like tinnitus and things like vertigo that can also be accompanied with this. What I really want you to remember is that there is a very specific pathogen that is most often associated with sensory neural deafness. What is the most common bacterial cause of acute bacterial meningitis? It is Streptococcus pneumonia. So Streptococcus pneumonia is going to be a very high incidence of leading to cochlear damage and cranial nerve 8 damage. And if you damage the cochlea or you damage the cranial nerve 8, that is what precipitates the sensory neural deafness. One of the things that we try to be able to reduce this incidence is whenever you get strep pneumo, it's going to cause an inflammatory reaction. That inflammatory reaction can be potentially mitigated by giving antibiotics, by giving something prior to the antibiotics. And that's what we're going to talk about later in the treatment section. But you may be able to prevent this. This theoretically could be prevented with dexamethasone. All right, and the concept behind this, and then also just early identification too. So early identification of the actual condition is going to be really, really important. But the concept behind this is that if you actually give this patient dexamethasone and you give that prior to the antibiotics, you may be able to reduce a lot of the inflammatory reactions that are causing some of these potential complications. And so that's really, really important. The other thing I actually get really worried about with this condition is when patients get meningitis. Not only can it cause cochlear damage, can it cause cranial nerve 8 damage, but imagine here you get some of this infected material in the meninges, and a part of the meninges, if you guys go back, we have, what is this structure here called? Here's the bone, then the orange is the periosteal layer of the dura mater, the green is the meningeal layer of the dura mater, then you have your subdural space, your arachnoid mater, your subarachnoid space, and the pink is the pia mater. Well, here in that subarachnoid space is the cerebrospinal fluid. And what happens if you get some of these pathogens that get into this subarachnoid space? What happens is the subarachnoid space is supposed to carry CSF to the arachnoid, kind of like these little valves, and then push them off into these little venous structures, the cerebrovenous sinuses. These pathogens can alter that process. They kind of imagine it clogs up the arachnoid villi. If it clogs up the arachnoid villi, you then can't push any of this CSF into that vein. What happens then is you end up with cerebrospinal fluid building up. So there is a CSF buildup. And now this occurs primarily where in the beginning? The subarachnoid space. So it's going to build up in the subarachnoid space. When this starts to build up in the subarachnoid space, you have to remember what the subarachnoid space connects with. So here's going to be the actual arachnoid matter here in blue with all these like little lines, these little trabeculae. And it connects to your foramen luschka and then your foramen magendi, which is going to be connecting to the fourth ventricle. Then you have your cerebral aqueduct, the third ventricle, and the lateral ventricles. So what's going to happen is this stuff is going to start backing up. And when it starts backing up, it's going to make it harder. So the pressure, it's going to be harder for things to move down in this direction. So things always want to flow from the lateral ventricles to the third ventricle, to the cerebral aqueduct, to to the fourth ventricle, but now you have this back pressure from the subarachnoid space. And what that's going to do is it's going to make it harder to drain. And if it's harder to move this stuff in that normal direction, what's going to happen to all of these beautiful ventricles? They're going to start ballooning up. And then you're going to start seeing some enlargement of the ventricles. And what is this condition called when you have an enlargement of the ventricles? Well, we call that ventriculomegaly, right? But specifically, the enlargement of the ventricles to the point where it's due to some kind of obstruction is really referred to as hydrocephalus. All right, so this is called hydrocephalus. So hydrocephalus in this potential scenario is due to infected material in the subarachnoid space clogging off the arachnoid villi, leading to a CSF buildup. That CSF buildup then leads to a decrease in CSF flow. So now you're going to have decreased CSF flow via ventricles. And then what that is going to do is that is going to lead to this potential condition called hydrocephalus. Now there's a very specific type of hydrocephalus in this scenario. Do you guys know what it's called? So there's one where you can obstruct it with something inside or outside. So something's inside the actual ventricle or the cerebral aqueduct and it's obstructing the normal flow. Or you have something outside that's compressing it and effacing it and making that little area smaller. That's called obstructive hydrocephalus. In this case, there's not something that's compressing it or obstructing it inside. It's something that's communicating with the subarachnoid space. It's causing this back pressure, making it harder for things to move forward. That's called communicating hydrocephalus. So this is specifically called a communicating. So this is called communicating hydrocephalus. Now, in patients who have hydrocephalus, what would be their potential clinical picture? Do you guys know? Oftentimes, with this one, it's pretty straightforward, right? Tinnitus, vertigo, or deafness. For hydrocephalus, the symptoms kind of depend on the degree of the severity. So the problem with hydrocephalus is whenever you have a decreased amount of CSF flow, it's going to cause the ventricles to get bigger. So it's going to lead to ventricular enlargement, right? So your ventricles are going to get enlarged. The problem with that is that whenever you cause the ventricles to enlarge, it kind of increases the amount of overall CSF inside of the skull. And what that can do is that can increase your intracranial pressure, which we'll kind of get into in a little bit. And so that's one really concerning feature here is an increased intracranial pressure. So what we look for with elevation of ICP due to hydrocephalus is a couple different things. One is they're going to have headache. That's obviously something that they probably already had prior to this with the underlying diagnosis of meningitis. But the other thing that we get concerned about with high ICP is things like nausea and vomiting. That can be due to the activation of the chemo trigger zone. The other thing that we can have is if we do a fundoscopic exam and we look all the way at their optic disc, we can notice some swelling of the optic nerve sheath and around that particular area called papilledema. All right, papilledema on fundoscopy. So if we notice papilledema on fundoscopy, that is also concerning, and that could be an indication of high ICP due to this hydrocephalus. And the last thing that we actually get worried about is when we think about it, I don't have a structure here, but you have what's called your anterior cranial fossa, your middle cranial fossa, and you go posterior cranial fossa. The sixth nerve is probably one of the most sensitive to increased ICP. So whenever the sixth nerve is moving up, it runs across a structure called the clivus. And whenever the pressure's high, it smashes it down on that. And the sixth nerve is supposed to cause what extraocular movement? It's supposed to control the lateral rectus. And so what happens is it alters that movement and it can lead to diplopia or double vision. And so you want to watch out for diplopia. So these are usually due to the potential things that I want you guys to think about in association with a patient having hydrocephalus. So this, in that hydrocephalus is going to explain their increased ICP. It may be associated with nausea, vomiting, papilledema, and diplopia. The next thing that I want you guys to think about associated with meningitis, and this one is actually kind of interesting. I don't want to go super crazy, but it's actually been seen with it, is cerebral venous sinus thrombosis. And we see this with both meningitis, and we actually can see this in brain abscesses too. But one of the things here is it's actually pretty kind of simple to think about it. So when a patient has meningitis, they have these pathogens that are along the meninges. Well, think about this again. Orange is the periosteal layer of the dura mater. Green is the meningeal layer of the dura mater. Then what is this part here, this blue one? That's the arachnoid mater, and then the pink one is the pia mater. Well, if you guys remember, the meningeal layer of the dura mater breaks away from the periosteal layer and creates this thing called a falx. In this case, let's say it's the falx cerebri, and that's where a cerebral sinus sits. And that's usually, and for this example, the falx cerebri, it's the superior sagittal sinus. If you have all of this infected material of the meninges, and it's pretty diffuse, right? We talked about that can be really, really diffuse. That inflammation is going to cause a localized kind of phlebitis. So there's going to be all of this inflammation here. That inflammation is going to be localized and it can cause phlebitis. And that phlebitis, inflammation of that vessel, can increase the risk of thrombosis. And if I clot off this vein, I impede the cerebral venous drainage. And that's what we get worried about, is we get worried about basically a phlebitis, which is going to increase clot formation in that area. And this is usually more of like what we call suppurative thrombophlebitis. And this is basically going to be due to an underlying infection like meningitis. And that is going to cause inflammation of the vessel. That inflammation is going to increase the risk of clot formation. And that clot formation is what we're going to see some problems with. All right, so now if we have some type of let's say again, meningitis and it's affecting the nearby veins that are in that kind of location of that meningeal irritation and inflammation, yeah, we could definitely develop thrombosis. And so you have to think about the potential veins that are actually located here. So for example, let's say that you have this top one here. This is called your superior sagittal sinus. Here, you're going to have another one which is called the inferior sagittal sinus. All right, so here we have the superior sagittal sinus. Here we have the inferior sagittal sinus. You also have another one here called the great cerebral veins. I don't want you guys to go too crazy with that one. And then another thing is that the inferior sagittal sinus usually empties into this confluence via something called the straight sinus. Then you're going to have this one over here after the confluence, and this is going to be called your transverse sinus. And then lastly, you're going to kind of bend it and move it downwards, and that's going to be called your sigmoid sinus. All right? And that's going to be this one right here. And then after that, you also have something called the cavernous sinus and the superior and inferior petrosal sinus, which are supposed to eventually empty down. The whole point is that the sigmoid sinus eventually will empty downwards into something called the internal jugular vein, which drains that out of the actual skull and into the internal jugular system, which will then take that back down to the right atrium, right? Whenever you have any kind of condition like meningitis, it can actually cause pretty diffuse inflammation of the meninges, where you can definitely get superior sagittal sinus thrombosis, inferior sagittal sinus thrombosis, transverse sinus thrombosis, sigmoid sinus thrombosis. The important thing to remember is that brain abscesses oftentimes go with these as well. I won't go crazy, but I want you guys to think about this for a second. If a patient has a frontal lobe abscess, let's say that they had a frontal sinusitis, maybe they had a sphenoid or ethmoid sinusitis or something like that, and the infection spread via the actual bone or via the small veins, it can cause a frontal abscess. But what also could it gain access to? The superior sagittal sinus. So they could get superior sagittal sinus thrombosis. If a patient had, let's say, acute otitis media, or they had mastoiditis and it lead to a temporal lobe abscess, what structures are really close to that temporal lobe? The transverse sinus and the sigmoid sinus. So these tend to be the most three affected. So these are the ones that are most affected often by conditions such as brain abscesses and meningitis. All right? Now, the symptoms of these are kind of depending. Superior sagittal sinus thrombosis is pretty nasty. It can definitely cause increased ICP. It increases the risk of having what's called venous infarcts, where there's so much back pressure because you can't get blood out of the vein. The blood backs up, and it halts or impedes the normal cerebral artery perfusion. And so you don't get as much oxygen to that actual brain tissue, and it can infarct. Or it can cause enough back pressure that the veins start to rupture and you bleed into the brain. So you can get venous hemorrhagic kind of changes as well. So that's really, really important. With these, These usually are going to potentially cause some kind of change, particularly you may have pain within like the ear area, and also just the other nearby structures that we want to talk about. So here's the last thing I want to think about. With cerebrovenous sinus thrombosis, then we talked about this one very, very briefly. This was called the cavernous sinus. We'll talk about this a lot in the infections, particularly for the EENT infections. But the cavernous sinus is important because it's very, very highly associated with, again, CNS infections as well. So let's say, for example, here, I have what's called the sphenoid sinus. All right, so here's your sphenoid sinus. And that's why if you get some type of sphenoid sinusitis, that infection can spread where? Right to the cavernous sinuses, right? And so that's one important thing. You also have these kind of like small little emissory veins that come from parts of the face as well. So if you get an infection somewhere, again, frontal, ethmoid sinuses, that can also spread there as well. But if an infection spreads here to these structures, again, what are these called here? These are called your cavernous sinus. So this is called your cavernous sinus. The cavernous sinus is really important because there's a couple different structures that run through it, all right? One is you have the internal carotid artery. So the internal carotid artery actually runs up through this puppy right here, all right? So you have an internal carotid artery that runs up through here. That's one thing. But the other thing here, let's actually do this in orange, is you have some nerves. You have cranial nerve 3, cranial nerve 4, cranial nerve 6. And then you also have cranial nerves, particularly 5, 2 different divisions, V1 and V2. So again, which are the actual cranial nerves here? This is going to be cranial nerve 3, cranial nerve 4, cranial nerve 6, and then you have the V1 division of the actual trigeminal nerve. And then over here, you'll have the V2 division of the actual trigeminal nerve. So we'll have V2 of cranial nerve 5, and then V1 of cranial nerve 5. So these are going to be the different kinds of cranial nerves that we can have here. And the reason why this is so important is that when actually a patient develops some type of infection, let's say if there's sphenoid sinus, so say here we have an infection, and this infection occurs at the sphenoid sinuses. So you get a sphenoid sinusitis. That infection can then spread here to the cavernous sinus. And when it spreads to the cavernous sinus, this can cause enough inflammation in this area where it actually can start to compress on these cranial nerves. And that can increase the risk of something called cavernous sinus syndrome. So cavernous sinus syndrome. And this is oftentimes associated with meningitis and brain abscesses. And usually what happens is because you're compressing things like 3, 4, 6, and also the other thing is that this is literally directly behind the eyes. It can actually cause so much bulging of the eye. So we call that proptosis. It can also cause swelling of the actual conjunctiva. We call that chemosis, and then cause a lot of orbital pain. But also on top of that, it affects the actual extraocular movements, and that's called ophthalmoplasia. So usually the things that we see with this is we see the patient will have severe pain behind the eye. So they'll have orbital pain, but they'll also have associated proptosis, which is kind of bulging of the eye. They'll have chemosis, which is a really, really significant swelling and redness of the conjunctiva. And the next component here is ophthalmoplasia, which is basically you have this difficulty or this weakness of the extraocular muscles due to 3, 4, and 6 being altered, and you can't move the eye in the appropriate directions that you need to. And so this is what we can see potentially with cavernous sinus syndrome. And again, we'll talk about this a lot in the ENT infections, but we definitely can see this commonly associated with potentially brain abscesses, and we can see this oftentimes associated with meningitis. So that's what I want you to know, is that these kinds of problems here can be associated with brain abscess and meningitis. It's not to say that they are a common cause of cavernous sinus syndrome or cerebrovenous sinus thrombosis. They oftentimes just happen to go hand in hand. The reason why I'm mentioning this is that oftentimes when a patient is diagnosed with meningitis, we'll do like a CT scan, a non-contrast, we'll find that they have kind of this ring-enhancing lesion. Oftentimes we'll do other studies like CTVs, which is a CT venogram, or sometimes if we do an MRI, we'll do an MR venogram. And the purpose of that is to help to kind of really see if there is any of those cerebrovenous sinuses that are thrombosed and kind of affected. All right, so the next thing that I want to kind of finish off with is, again, we know that patients who have meningitis have an increased risk of sensory nerve deafness. It's actually probably the most common complication. It can be transient, oftentimes can be permanent as well. Communicating hydrocephalus is a really, really big one because it contributes to an ICP crisis. And cerebrovenous sinus thrombosis, especially with that little one that we talked about called cavernous sinus syndrome, they're oftentimes associated with things like meningitis and associated with things like brain abscesses. It's not all the time, and it's not often that the condition itself, such as meningitis and brain abscesses, cause on its own things like cerebrovenous sinus thrombosis. It's something that you're actually going to see probably most often kind of correlating with one another. The whole purpose of that is that, again, that when we're doing CT scans, finding these things like brain abscesses, we're probably also going to be adding on CT venograms or MR venograms to really see, hey, here's the abscess, but also is there any other kind of associated nearby venous sinuses that are afflicted because they came from a shared source? A frontal ethmoid sinusitis, a dental abscess, otitis media, etc. All right? The last thing I want to talk about here with meningitis, and I told you I was going to talk about this when we talked about the etiologies, is Neisseria. So Neisseria, meningitis. So I'll write this guy out. Neisseria meningitis is a gram-negative diplococcus. All right, so a gram-negative diplococcus, and this thing is super nasty, man. It releases lots of like different types of endotoxins, like lipopolysaccharides. And these endotoxins, they lead to a bunch of different issues. One of the big problems here is that they can increase the production of things like tissue factor and other kind of coagulation enzymes, but also it can trigger an increased production of things like interleukin-1, interleukin-6, tumor necrotic factor alpha from a lot of our endothelial cells and our immune system cells. So this is going to be a really, really problematic thing, is that these things are pumping out the endotoxins. And again, these endotoxins are sons of guns because they can increase the activity of things like tissue factor, which is an important part of our coagulation cascade, and our pro-inflammatory cytokines like interleukin-1, interleukin-6, TNF alpha. Now, why is that important? Well, if you increase tissue factor and maybe other coagulation enzymes, what's going to happen is you're going to increase the activity of the extrinsic pathway, push them down to the common pathway, and lead to clot formation. Now, let's say that you do that and you cause a bunch of clots to form all over the place. Now you have tons of these things called microthrombi. All right, that's one potential issue here, is that you have tons of these microthrombi all over the place because you're activating the coagulation cascade. The other problem here is that if you cause so much coagulation activity, you consume so many of your clotting proteins. And so that's the other issue, is that you make so many clots that eventually you run out of clotting proteins and you run out of platelets. And I'll explain another reason why you run out of platelets. And that basically increases the risk of bleeding. All right, so they also will have not only clots, but they'll also have bleeding. All right, and that bleeding is again due to the consumption of our clotting proteins. So they're going to have a lot of bleeding due to the consumption of clotting proteins. So you're going to see clots and you're going to see bleeding, which seems paradoxical, right? The reason why this is important is because this kind of combination causes the presentation of something that we get concerned about called DIC. So I know you guys have heard of DIC. We talked about, I think, like 1,000,000 times in hematology. But with DIC, it's some kind of process that increases the risk of widespread clots that consume your clotting proteins that precipitate bleeding. So what would we think about with DIC? Well, if I consume clotting proteins, we look at clotting proteins and we measure their activity via the PT, the PTT, or the PT-INR and the PTT. That's one thing, right? Now, when we think about PT-INR, and we think about PTT, these are measuring the activity of the extrinsic pathway and the extrinsic pathway, intrinsic pathway. These will be elevated. It's going to take a longer time now for these patients to clot because we're consuming all of their clotting proteins. The other thing is, we look at something which is kind of a measure of clot burden, which is called D-dimer. And that's going to be through the roof because you're forming tons and tons and tons of clots. And so I should also expect a bump in the patient's D-dimer. The other thing is, whenever we are actually kind of doing this kind of process where we're really making a lot of clots and we're consuming a lot of the clotting proteins, the other thing is that you run out of very specific proteins that you need to help with the clots. And that's called fibrinogen. That's one of those really, really important clotting proteins. And you're consuming so much of it to make clots that you run out of it. So the fibrinogen levels tend to be pretty low as well. And then one other thing that's oftentimes associated with this condition is that whenever you have these microthrombi, you're supposed to have things like red blood cells and platelets that are running through here. And what happens is you shred up the red blood cells, right? And these are called schistocytes. That's one thing. But the other thing is that you're consuming a lot of the platelets. And so that's one thing that happens is as red blood cells are moving through here, you're shredding them up and you get things called schistocytes. But to make these microthrombi, what do you need a lot of? You need a lot of platelets. And so platelets get consumed like a son of a gun. I actually need my maroon marker here. So the platelets are going to be consumed to make a lot of these microthrombi. So we need those platelets there to help us to make these microthrombi. So what would I expect to happen to my platelet levels? I expect that to go down because I'm consuming them puppies, right? So my platelets will go down. And if I'm ripping up red blood cells, what do I expect to go down? My hemoglobin and the hemoglobin. And usually this is why we would see anemia. Usually this is a type of hemolytic anemia. So I would see thrombocytopenia, maybe a hemolytic anemia, and I would see all of these kind of abnormalities in my coagulation parameters. So this is what we get concerned about with Neisseria. And I think that's a very good reason to be concerned. The other thing here is that these endotoxins also are problematic because they cause a lot of these cytokines to be pumped up. And what these do is they work on our blood vessels and they cause our blood vessels to undergo vasodilation and increase capillary permeability. So whenever you cause vasodilation, so we're going to really blow these puppies up, we're going to increase the actual diameter and we're going to increase the capillary leakage. What's that going to do to your overall blood pressure? It's going to drop that son of a gun like a bad habit, right? So we're going to see two things here, vasodilation and increased capillary leak. The combination of this, the vasodilation will drop your systemic vascular resistance, and that's going to drop your blood pressure, and the capillary leak is going to cause you to lose fluid. It's going to cause third spacing. It may cause a little bit of a hypovolemia or decreased effective arterial volume. And that blood volume drop will drop the appropriate blood pressure. And this is where we see patients going into shock. And usually this is a type of septic shock, right? So that's something I want you guys to think about is usually with these patients who have Neisseria meningitis, we may see shock, we may see DIC. And here's one other thing to kind of go with this. This is kind of interesting. So for right now, I'm just going to move the hemoglobin out of the way. Whenever you kind of consume your platelets and you cause all of these kinds of bleeding processes, we may see some associated, especially with the DIC, we may see some rashes. And this is one of the key things that we see associated with this condition is they may see what's called a petechial or purpuric rash. And that is almost always going to be present on your exam and it's going to scream Neisseria meningitis. So if you see a patient who has a petechial purpuric rash, maybe they have some coagulation abnormalities, maybe they're really, really septic appearing, you want to think about Neisseria. Another way that they will do this, I won't go too far, but this also can get in your joints. And it can also cause septic arthritis. And so sometimes one of the ways that they'll actually present is that they're having difficulty ambulating. So don't forget about that one as well. The last thing I want to talk about is whenever a patient has this severe hypotension and they have this DIC, both of these things kind of really just piss off the adrenal gland really, really bad. And so what happens is, I'd say more likely often than not, is this bleeding and kind of like processes of clotting and bleeding inside of the adrenal gland, and probably even a combination of hypoperfusion. It just really, really jacks up the adrenal gland. And what happens is they undergo this bilateral kind of hemorrhaging inside of the adrenal gland, and this just it's so bad. It really knocks off their cortisol levels and it knocks off their aldosterone levels. All right, so they experience kind of like an adrenal insufficiency essentially. So they have low cortisol and they have low aldosterone. Now I want you to think about this for a second. If your adrenal gland sucks in this scenario and it can't pump these bad boys out, what could I expect? And a couple of things. If we can mash these in here, right? Well, aldosterone is supposed to reabsorb sodium. Are you going to be able to do that? No. So I see a drop in the sodium. It's also supposed to secrete potassium. Can you secrete potassium? No. So the potassium goes up. And what's cortisol do to your glucose levels? Increase it. If you don't got cortisol, what happens to your glucose levels? Drops. And so we're going to see a drop in the glucose. And so oftentimes you may see these electrolyte and nutrient abnormalities such as hyponatremia, hyperkalemia, and hypoglycemia. This, in a combination with also cortisol, is also important for being able to control your blood pressure. Aldosterone is supposed to control your overall sodium and water reabsorption, so your blood volume can drop. This patient could also worsen their blood pressure, so we would experience a rapid worsening of their blood pressure. This here, I'm going to give it my best go here, guys. This is called Waterhouse-Friderichsen syndrome. And this is essentially whenever there is bilateral adrenal hemorrhage. And that bilateral adrenal hemorrhage leads to a loss of cortisol, a loss of aldosterone. They experience electrolyte abnormalities, glucose abnormalities, and rapid worsening of their blood pressure, oftentimes associated with meningococcemia. All right? So that's what I want you to take away from this with Neisseria meningitidis is Neisseria meningitidis can be associated with a petechial purpuric rash. It can be associated with severe hypotension. It can be associated with DIC, and it can be associated with an adrenal crisis. Overall with meningitis, the big complications I want you to associate this with is sensory neural deafness and communicating hydrocephalus. This here is more often a result of a shared source of infection between meningitis and this condition rather than a sole result of meningitis and brain abscesses. Let's now move on to the next complication associated usually with encephalitis. All right, so encephalitis is one of those things where, again, you think about a patient with fever, you think about headache, you think about an altered mentation, you think about some type of change in their memory, behavior, speech, such as aphasia, and high incidence of seizures. Encephalitis, I'd say, again, meningitis can increase the risk of seizures, brain abscesses can also cause seizures, but the one that carries the highest incidence of seizures is going to be encephalitis, right? So that's the one that I want you to think about. So again, there's some type of inflammation of the brain parenchyma. Most often, it is the temporal lobe. And the temporal lobe is just a very, very sensitive area for some type of seizures to occur. Now, with these seizures, if you develop seizures, oftentimes what we get worried about is, if they become focal or if it gets to the point where they start to become generalized, right? So that's what we get worried about is focal versus generalized seizures. All right, so could this be focal? Depending upon the area, that will determine the actual type of presentation they have, or is it going to be generalized? So focal meaning that you may have a focal, tonic-clonic movement of one extremity, right? Whereas if you have a generalized seizure, this may precipitate a full body tonic-clonic convulsive seizure. Now, the other thing I want you guys to think about with seizures is, with these, you run the risk of something called status epilepticus. And status epilepticus is this, you have seizures for more than or equal to 5 minutes, or you have a seizure that you don't return back to your baseline, if you have seizure and seizure in succession. That's what we get concerned about with is status epilepticus. With another concept here of seizures is, again, I really need you to remember that if I talk about them in order of commonality, so order of, let's say, commonality, we'll just use that term. Order of commonality here. You would start off saying that encephalitis is going to be the most likely to cause seizures. Then you would go to something like a brain abscess. And then after that, you may kind of move forward into something like meningitis. So all of these definitely carry a risk of seizures. It's just most often you're going to be thinking about this one with encephalitis. All right, again, that is going to be encephalitis. Encephalitis definitely can cause other potential complications. It's just the thing I want you to associate it with is seizures. Meningitis, I want you to associate it with sensory neural deafness, communicating hydrocephalus. And think about that DIC, shock, and Waterhouse-Friderichsen syndrome with Neisseria or meningococcal meningitis. I gotta be careful with the way I say meningococcal. All right, let's move on to the next part, brain abscess. All right, so let's now move on to brain abscess. So when we talk about brain abscesses, again, meningitis, you worry about that, particularly the communicating hydrocephalus, the sensory neural deafness, that's the big things. Encephalitis, you really worry about seizures. But again, remember, meningitis can cause seizures, brain abscesses can cause seizures as well. It's all, as long as you have cortical irritation, you can get a seizure. It does not matter. Now, if that brain abscess is a little bit more subcortical or it's cerebellar, you may not see any kind of like seizure activity. But if that brain abscess is near the frontal lobe, the temporal lobes, or near those gray-white junctions and they're scattered, but they're near the cortex, you can 100% have an increased seizure risk. But meningitis, encephalitis, and brain abscesses, cortical brain abscesses, increase the risk of seizures. With brain abscesses in general, a couple of things I want you guys to think about, and I think it's important to think about this because it really carries a high risk of mortality, is a abscess rupture, all right? So what I mean by this is it can increase the risk called a ventricle, let's say ventricle rupture. So let's say here you have an abscess, and it's very, very close to an associated ventricle. And what happens is that abscess kind of starts getting close and close to the wall of that ventricle, and then all it does is it literally empties its contents into the ventricles. Well, what that's going to do is that's going to cause a couple different issues. One is if the infected material gets bad enough, it can cause maybe an obstruction, maybe it can go clog up the arachnoid villi, and that can increase the risk of things like hydrocephalus, right? But the concerning feature here is you run the risk of something called ventriculitis. And ventriculitis is pretty terrible. It's one of these things where these patients oftentimes don't do very good. You oftentimes have to put them on things like intrathecal antibiotics to really help to clear this stuff out. Sometimes they need VP shunts because it can cause communicating hydrocephalus, but usually if an abscess does rupture into a ventricle, it can really produce a prolonged kind of course for them, such as ventriculitis, and that ventriculitis definitely can increase the risk of things like communicating hydrocephalus. So I would write down that this does carry a higher risk of something called communicating hydrocephalus. High risk of communicating hydrocephalus. Oftentimes with these kinds of conditions, you may need those long-term things like VP shunts to help them out, all right? But that's something I want you guys to understand here. The other concept is that these brain abscesses, they can have mass effect. And when you have mass effect, imagine that I'm kind of pushing on this ventricle here. Imagine I'm squeezing on it. By doing that, when you compress at a particular area, you impede flow. So let's actually kind of pretend here for an example here. Let's say here, I have the ventricle, and then this abscess is going to squeeze, let's say, right here, right at this point. If it squeezes right here and it compresses in this area, it can then narrow the ventricle. So let's then say here as an example, it's going to narrow this ventricle. If you narrow that ventricle, it's going to impede the normal kind of downward CSF flow. So CSF is going to want to try to be able to move down this way, but we're going to inhibit that process because we're going to exhibit some mass effect. By doing that, when you inhibit this, you build up the pressure inside of the ventricles. And what happens to this ventricle? It gets larger. And that's when they start to experience some enlargement of the ventricles. What's that called? Hydrocephalus, right? So usually these patients exhibit something called hydrocephalus, but it is due to not a communicating process, it's an obstructive process. Something that is blocking the flow of CSF downwards because this brain abscess is mashing there. Maybe it's mashing on the third ventricle, maybe it's mashing on the cerebral duct, maybe it's mashing on the fourth ventricle. All of these things, that hydrocephalus, we know it does what? Increases things like nausea, vomiting, papilledema, and diplopia. And so those are all potential symptoms of hydrocephalus. The last thing that's probably the most concerning with a brain abscess is the risk of herniation. Usually when you have these types of processes where you have a brain abscess, if they're large enough, they're going to exhibit mass effect. And that mass effect can start kind of pushing things in opposite directions. So let's imagine you have an abscess here that's pushing brain structures this way. It can herniate parts of the actual brain matter underneath the falx. Or let's say that you have a brain abscess here and it's pushing the uncus over this way. Or maybe you have one somewhere within the basal ganglia and it's pushing things down in the brainstem. Or maybe you have one here in the cerebellum and it's trying to squeeze pieces of the cerebellum out through the foramen magnum. Well, these are called herniation syndromes. And so you have 1, 2, 3, 4. So 1 is referred to as a subfalcine herniation, right? So we call this subfalcine herniation. 2 is called uncal herniation. 3 is called, some call them a diencephalic shift or a and this is a downward, transtentorial herniation. And then 4 is called tonsillar herniation. The problem with this is that these all produce specific neurologic deficits. Usually subfalcine herniation compresses the ACA territory, they develop contralateral hemiparesis. With uncal herniation, they develop a third nerve palsy where they have a dilated and non-reactive pupil and sometimes contralateral hemiparesis. Transtentorial is you're pushing down in the brainstem, so they have a declining level of consciousness. And sometimes they can have some changes in their pupils where it's more midline position and fixed. And then tonsillar herniation is you're kind of compressing and pushing the tonsils out from the foramen magnum and then get kind of cardiopulmonary arrest and Cushing's triad types of presentation. So that's what we get worried about is this type of herniation. And that's why sometimes in the exam, what you'll see is it's harder to pick this out. So the whole concept is if I have a patient who has a brain abscess, I get a CT scan, I find the brain abscess, what else should I be looking for? Hydrocephalus. What else should I be looking for? Is the abscess very, very close to the ventricle? Is it opening up into the ventricle? With herniation, do I see any evidence of herniation syndromes? And then lastly, clinically, I want you to always coordinate this with specifically something called the Cushing's triad. So this is all herniation, but correlate this with the Cushing's triad. Do you guys know what the Cushing's triad is? I know you do. Come on, let's write it out. What's the Cushing's triad? So the Cushing's triad is a couple different things. One is with that triad we get worried about. One component is heart rate, the other one is blood pressure, and the other one is respirations. So this is heart rate, blood pressure, respirations. What I want you to do is I want you to remember the heart rate will drop, they'll become bradycardic. The blood pressure will go up, they'll develop a reflex hypertension. Or actually, they'll cause hypertension to try to perfuse the brain, and sometimes it develops a reflex bradycardia, or sometimes that bradycardia is due to a loss of the cardiac acceleratory center activity. And then usually the last thing is irregular respirations. So irregular respirations. All right, so the Cushing's triad is again a low heart rate, an increased blood pressure, and irregular respirations. That is what we refer to as the Cushing's triad. So if I have a patient coming in, they have maybe headache, fever, they have some focal deficits, and then they also are presenting with a declining level of consciousness. Maybe they're presenting with a high blood pressure, a low heart rate, irregular respirations. Level of consciousness is really kind of declining. What should I be concerned about? I'm worried about herniation type of presentation. And that CT scan will really help me to identify that. The last thing that I want to kind of talk about is, again, it's kind of going along with the herniation, is the most common feared complication among all of these three, meningitis, encephalitis, and brain abscess, is an ICP crisis. So whenever the patient's ICP goes up, whether that's due to hydrocephalus or whether that's due to diffuse edema, or whether that's due to blood, whatever it is, the ICP increases the risk of brain herniation. And that brain herniation is what increases the risk of death. And that's what we get concerned about, right? So let me kind of explain here something. We've probably talked about this a lot. And again, I don't want to go crazy on the neurological complications. I know it probably seems like it, like I'm doing that right now, but I promise we're going to talk more about these in neurology because I want it to make more sense there. Infectious disease should be kind of maybe thinking, hey, what are the potential complications? And the reason why I talk about these complications is because we actually treat these kind of alongside their underlying meningitis, the underlying encephalitis, the underlying brain abscess. But I don't want to go through crazy mechanisms and pathophysiological processes. I want to briefly talk about something called the Monroe-Kelly doctrine. So it says that The skull controls a fixed space which occupies the brain, the blood, and the CSF. So we're going to represent the black here as the brain matter. We'll represent the blue here as the CSF, and we'll represent the red here as the blood. All of this is what sits inside of the skull. If you increase one of these or multiple of these more than what they're supposed to be, it's going to increase the ICP. That's what I want you to think about. So if a patient has meningitis, how does that increase the ICP? Well, one thing it does is it increases your brain edema. So it causes something called vasogenic edema. So it basically you lose the capillary foot process, kind of like connection at the blood-brain barrier, and fluid can leak from the actual capillaries or vessels there into the brain tissue and cause associated edema. So that's one mechanism. The other one is it can cause hydrocephalus. So it's going to cause edema, so brain edema, and that's going to increase ICP. And it also can cause hydrocephalus. Which type of hydrocephalus? Most often, communicating hydrocephalus. But the combination of these is going to increase ICP, because edema is going to do what? It's going to increase the amount of brain matter, your swelling of the brain matter. Hydrocephalus is increasing the CSF. Inside of the skull, there's a fixed space. That's going to increase the ICP. If the ICP goes up enough, you can present with herniation syndromes and Cushing triad presentation. What about encephalitis? It primarily acts by causing diffuse cerebral edema, especially in the temporal lobes. It doesn't oftentimes have any kind of effect on the patient's what? Ventricle size. And so because of that, that would be the primary way of the patient increasing their ICP. The last one here runs that really scary risk. With brain abscesses, they can definitely cause mass effect. You're having a big lesion inside of the brain tissue that's occupying more space and exerting mass effect. And so one of the things that we'll see here is we'll see an increase in mass effect. And that mass effect is just due to the underlying brain tissue, in this case, the infected tissue, and that's going to exert an increase in the ICP. The other one is hydrocephalus. What kind of hydrocephalus? Most common is obstructive. And so it's going to compress on a ventricle and impede the flow, increase the CSF, and that is going to cause a problem with the ICP. So mass effect is going to be one problem, hydrocephalus is another one, and the combination of these will increase the patient's ICP. You increase the patient's ICP, you run the risk, depending upon where that lesion is, the underlying process, of herniation syndromes and Cushing's triad, right? So my friends, that really leaves us kind of like talking about CNS infections with respect to how did these pathogens get into the brain? How do we then think about the underlying etiologies? What is the most likely pathogen causing bacterial meningitis, viral meningitis, encephalitis? What is the most common causes of brain abscesses depending upon if there's pyogenic, non-pyogenic, solitary, multiple? And then from there, how do we think about CNS infections clinically? Do they present with fever and headache? Yeah, all of them. Well, which ones present more with the meningeal signs and which ones present with more of the cortical signs? That helps us to kind of think about that and kind of develop a nice differential diagnosis. And oftentimes you may get those presentations, but sometimes the patient may come in with a new onset seizure. Sometimes they'll come in with features of increased intracranial pressure due to hydrocephalus or due to mass effect. And those are the things I need you to think about. Also, sometimes as a result of their underlying disease, even though you treat them appropriately, they may develop complications such as cerebrovenous sinus thrombosis, sensory neural deafness, and seizures. And that's what I really want you guys to kind of start putting all of this together. So now what I want to do is let's take a step back. We've really built our foundation. Let's say if I needed to know as a clinician, the bare minimum to say, here's how the patient's presenting, how do I figure out if it's encephalitis? How do I figure out if it's a brain abscess? How do I figure out if it's meningitis? And how do I figure out what the most likely pathogen is that can guide my empiric and then narrow treatment? Let's do that now. All right, my friends, let's now think like clinicians. Let's talk about the diagnostic approach. One of the most common classic findings, probably across the board of CNS infections, is fever and headache. A lot of them are going to present with a fever and headache, meningitis, brain abscess, encephalitis. I think that's kind of one thing to start off with. The next thing I think that adds to the utility that makes you even more suspicious of an intracranial process, or at least a CNS infection, is the presence or absence of meningeal signs and cortical signs. So meningitis will present with fever, headache, that's a very common presentation, and often meningeal signs. Whereas conditions like encephalitis, it usually doesn't have meningeal signs, and brain abscess doesn't often have meningeal signs. That's one thing to think about. Now, what are meningeal signs? We talked about this on the whiteboard, right? Usually, this is referred to as like nuchal rigidity, so neck stiffness. That's one thing. So neck stiffness, kind of limited range of motion with the neck. And going with that, if you try to have them do specific maneuvers, the negative presence of those maneuvers doesn't completely exclude the possibility of meningitis, but the presence of them does make you a little bit more suspicious of them. What do I mean by that? Well, there's two tests. One's called the Brzezinski's, and we talked about the Brzezinski's. When you're kind of flexing the patient's neck, it puts a lot of stress and tension on those meninges, and one of the responses to that is that they start to kind of flex up their hips and their knees. Another one is called the Koenig sign, where you're having them lay flat, you're bringing their hip into kind of a flexion point, and then what you're going to do is their knee is kind of like at a 90-degree angle, and you're going to start trying to extend that leg. And when you do that, it's going to precipitate pain and resistance to that type of movement. So the absence of the positive signs here does not exclude meningitis. That's really important to remember. There is a newer test. This goes a little bit beyond the likes of being tested on, but for clinical kind of discussion, there's called a jolt accentuation maneuver, where you're quickly moving their head from side to side. That may precipitate a lot of pain and stiffness and resistance to that movement. And the presence of that does scream a high likelihood of meningitis. And if it's negative, that almost completely rules out the possibility of meningitis. Either way, as clinicians, fever, headache, meningeal signs screams meningitis on the textbook. All right. For the cortical signs, that's going to scream more of the possibility of encephalitis and brain abscess. Meningitis may or may not have cortical signs. It depends if it's actually led to what's called meningoencephalitis. So meningitis doesn't often cause cortical signs. It can, it's just not as common. And encephalitis, 100%, there's inflammation, usually of the temporal lobe, where you're going to see a lot of these processes occur, especially things like seizures, cognitive behavioral changes. And brain abscess is usually an infection that's usually more encapsulated, and it's involving an actual brain tissue, a particular lobe that will cause associated cortical signs like focal neurodeficits. So, fever, headache, meningeal signs screams meningitis. Fever, headache, cortical signs screams encephalitis. What are those cortical signs that should make you think about these? That would often be an altered mentation. So if a patient's confused, if they're difficult to arouse and wake up, if they're kind of having difficulty being able to answer particular questions, knowing where they're at, right? Knowing what their name is, knowing what the year is, knowing who the president is. Those kinds of things kind of help us to understand if they're alert, if they're awake, if they're oriented to person, to place, to time. And so that's really important. Focal neural deficits are dependent upon the area that the actual encephalitis and brain abscess is. They may present with hemiparesis. They may present with a cranial nerve palsy. They may present with potentially aphasia. And so that's dependent upon the location of where the infection is. And then seizures, especially with encephalitis, if it's near the temporal lobe and it's involving the outer gray the outer gray matter, the cortical region, that's a high increased incidence of seizures, right? And then cognitive behavioral changes often we see with encephalitis because it's involving the temporal lobe, where we have structures like the amygdala, where we have structures like the hippocampus, things that are a part of your limbic nuclei that control not just your behavior, but also your memory. And so that's really, really critical to think of these things. So for example, if I said a patient had fever, headache, meningeal signs, you think meningitis. If I said fever, headache, altered mentation, cognitive behavioral changes and seizures, you really want to think encephalitis. And if I said fever, headache, and a focal neural deficit, that oftentimes more than not points to a brain abscess. Now, these aren't always perfect, so what I want you to always remember is when a patient has a fever, They present with maybe cortical signs, meningeal signs. You have a high degree of suspicion for a CNS infection. You need to get them on the proper antibiotics if it's a bacterial infection. The reason why is mortality can increase if you're not treating them. Before you put a patient on an antibiotic, you should always obtain blood cultures, because if you give them antibiotics and then you obtain blood cultures, you may sterilize those potential cultures. And so that's one of the things that you should always try to do, unless you just don't have an option. But try to get blood cultures first. That's why I kind of talked about this here, because in maybe 25% of cases, it may come up positive blood cultures, especially in the patient who has things like meningitis or abscesses of the brain. All right, so get those cultures before you start the antibiotics. The next thing you should do is, okay, I have a patient with a fever, headache, they have some cortical or meningeal signs. I think that they have a CNS infection. Get the blood cultures. Depending upon their presentation, I may start them on some antibiotics. I may add on some steroids right off the get-go, depending upon which one I think it is, right? But the next question that you have to ask is, I need to be working in tandem. So a lot of the times you're diagnosing and treating in the same parallel pathway. So in other words, I'm kind of thinking, okay, this could be meningitis, right? Let's say that I have fever, headache, meningeal signs. First thing I'm going to do is I'm going to get some blood cultures. I'm going to start them on empiric therapy. And then I'm trying to also at the same time, do I need to get imaging? Do I need to get an LP? And move through that process. How do I determine if a patient who I think has meningitis or has a CNS infection needs a scan? A non-contrast CT scan. We look at something called the fail signs. Do they have it or not? So what are the fail signs? The fail signs is, do they have focal neurodeficits? Do they have hemiparesis that's present? That's kind of one thing that's going to be possibly concerning. Do they have aphasia? Do they have sensory changes, cranial nerve palsies? I'd probably get a CT scan, right? The next thing is, do they have an altered mentation? We can be concerned about that, right? Because focal neurodeficits sometimes scream potentially a brain abscess. Altered mentation scream maybe encephalitis. Are they immunocompromised? So meaning HIV, did they have a recent transplant? The reason why is these patients are super high risk for brain abscesses. They're also super high risk for very scary types of meningitis that can quickly progress and become very, very, very sick. All right. The next one is a lesion. Do they have a known CNS disease, or do they have evidence of increased intracranial pressure? Usually on the exam, this is presented on some way, shape, or form where you've evaluated the eyes and you've somehow been able to see the papilla or the optic disc, and you see the papilla edema. That would be an indication to not stick a needle into their cerebrospinal fluid. All right. And then the last one is going to be the S, a new onset seizure. I want you guys to think about this for a second. The reason why you ask these questions is that if I don't do these things and I go ahead and I stick a needle into the cerebrospinal fluid and they have a brain abscess, they have a lesion that's actually present that's increasing their intracranial pressure, or they have a structural focus that's increasing their ICP that any of these things could explain, and I stick a needle into their CSF and I drop the pressure of their spinal canal, that could theoretically cause herniation. So a lot of these things are trying to reduce the risk of herniation and also identify if there is a brain mass in the process. All right. If they have these signs, you need to not do an LP right away, and instead you have to get a CT scan because you want to find any possible structural lesions that could explain their presentation and also avoid herniating them if you're going to get an LP. All right. If you do not have fail signs and they present with a CNS infection that concerns you for meningitis or encephalitis, you definitely want to get an LP. And so I would go right to an LP if they don't have fail signs, all right? Now, another reason I would do an LP is if I had fail signs, I got the non-contrast head CT, but it showed no brain abscess, no kind of lesion that was present, and I have a high degree of suspicion that they got meningitis or encephalitis. I'm going to get an LP. LPs are great for meningitis, encephalitis, non-contrast or CT scans, MRIs. Those are better for brain abscesses. You don't want to do an LP for a brain abscess. It's not going to help you. All right. Now, when we do an LP, all it's trying to do is test the cerebrospinal fluid. Because if you think about it, dude, what's a part of the meninges? You have your dura mater, you have your arachnoid mater, and you have your pia mater. What's the space in between the pia mater and the arachnoid mater, the subarachnoid space? So if you have inflammation, infection of the meninges, that's including the subarachnoid space. So what I want to do is I want to tap into that and test the CSF for bacteria, viruses, or fungi if the particular exposure risk factor exists. So I'm going to do that. I'm going to access their cerebrospinal fluid by going in, tapping in around that probably L3, L4 region, stick a needle in there. And then once I've done that, always a part of your process, especially if you're concerned for these patients, you should always do what's called an opening pressure. So what you'll do is you'll stick a needle in, you'll kind of pull the stylet out. Am I getting any fluid? Nope. Stick the needle further, pull the stylet out. Nope, no fluid. Stick the needle in. Oh, I got some fluid. All right. Take your next apparatus here, put it on, and what that's going to do is it's going to give you your manometry, your pressure. What's the pressure upon opening and accessing into their cerebrospinal fluid or their subarachnoid space? And that's important to determine because the higher the pressure is, the more it concerns you for possibly an abnormal infectious process. Usually anything kind of less than 15 is relatively normal, and as you go above that, it's obviously abnormal. Now, another thing is you have stopcocks on this that control the way that you want to then collect fluid. Usually you have tubes that you're going to collect in sequence, 1 to 4, and you're just going to keep collecting that CSF, taking a look at the color, taking a look to see if it looks purulent, does it look clear, does it look bloody? Those are key things. Usually bacterial is going to appear more cloudy. Usually HSV encephalitis appears bloody. And so that's something that you really want to consider, all right? Now, after we've done this, we're then going to take these samples, these 4 tubes, we're going to send it off to the lab and we're going to test it. When we test the actual fluid, we're testing it for a couple different things. Now, opening pressure, we already talked about that. That's something that you can do at the bedside. Opening pressure is oftentimes high in any type of pathology like bacterial meningitis, right? You're going to see it in viral meningitis and encephalitis. Sometimes it can be a little high, but another one that's really important is TB meningitis. This one can have a pretty high opening pressure, and the last one is cryptococcal meningitis can also have a high opening pressure. So this is something that may help you. If you tap in, you see a high opening pressure, that may make you think about bacterial, and if the exposure and risk factors are right, you could think about TB, you could think about cryptococcal. If the opening pressure is kind of normal or just on the verge of being a little bit elevated, you can think about viral meningitis or HSV encephalitis, right? The next thing is to actually send it off to the lab, and the lab will give you what's called a cell count with a differential. In other words, they'll tell you, do you have a lot of white blood cells that are present in the CSF? That means inflammation, right? And the type of white cells also can help to guide you to which type of pathogen to suspect. With polymorphonuclear leukocytes, which are just neutrophils, dude, that's going to be the predominant one. And it's going to be in the thousands. It's going to be pretty high for bacterial. Whereas usually with like viral meningitis, encephalitis, TB, cryptococcal, it's more often high white cells, but it's primary lymphocyte predominant. And that's what I want you to think about for these. All right. The next thing that you also want to get is you want to check what's called the glucose. The glucose tells you about the metabolic activity that's going on in there. If there's tons of bacteria, if there's lots of mycobacteria, if there's lots of fungus like cryptococcus, these things are going to chew through the glucose for their metabolic processes to divide and to grow. And so the glucose levels will probably be low for bacterial, TB, and cryptococcal, but they're going to be likely normal for your viral processes because they're not going to be dependent upon glucose. All right, so that should be normal, whereas these should be low. All right, we got the opening pressure down. Almost all of them are high except viral. Cell count. Bacterial is going to scream neutrophils in the thousands. Viral, TB, cryptococcal, they're lymphocyte predominant. And obviously with TB, they tend to have probably in the hundreds to thousands. Cryptococcal, hundreds to thousands. Viral is not super high. The next thing here is protein. Protein is really important as well. It's again a marker of kind of inflammatory processes. It's not specific. And guess what? All of them have high protein, so it's not really going to be super helpful. Okay? So with that being said, you kind of start stratifying, at least for the most part, bacterial and viral. That's really the big goal here, as you can easily distinguish between these two. All right? What you need to then tell you what is the likely pathogen is the gram stain, the cultures, the PCRs, any other miscellaneous test that you add that's dependent upon the patient's exposure, their risk factors. For example, for bacterial meningitis, the cultures, the PCR, that's going to give me the things that I really am concerned about. What are the most common pathogens? Go back to it. Ask yourself, what was the most common? Streptococcus pneumonia. That'll come up on this test. What was the other ones? Well, I told you to think about Neisseria meningitis and to think about Haemophilus influenza type B, right? Then I said, what if you have a person who's an alcoholic, they have cirrhosis, they're pregnant, they're old, greater than 50, they're immunosuppressed, listeria, right? And then the other ones that I told you to think about is this more particularly probably in the hospital-acquired realm. If they had an EVD, an Ommaya reservoir, they had a neurosurgical procedure and you tested it, you start thinking about things like Staphylococcus aureus, especially the MRSA, and then Pseudomonas aeruginosa, right? Those are for the hospital-acquired ones. And so this is where, again, we're kind of adding in what we talked about on the whiteboard and bringing it to place in life in the clinical world. The viral ones, you can send off a bunch of them. So when you do a PCR, you can do a viral panel and it's going to give you a bunch of them. But the only ones that we really want to know is the ones that we need to give them an antiviral. All of these are, once we find out the type, they're already on empiric antibiotics by now, right? So I had a patient come in, fever, headache, meningeal signs. They didn't have fail signs. They got the LP. Already in this time frame, they're on antibiotics. Once they get the cultures and it comes back with the specific one, we narrow the antibiotics down. So not only is it diagnostic, but it guides the particular antibiotic that you have to choose. That's why we're doing this in tandem, right? For viral, we only add on the acyclovir if I have concerns of HSV. Do they have cortical signs? In other words, if I can't confidently say that I don't think that they have HSV encephalitis, they need to be on acyclovir. That's important to remember. If they have altered mentation, if they have seizures that are new onset, if they have cognitive behavioral changes, I'm putting them on acyclovir until I get the PCR back. And if the PCR comes back negative, sometimes it could potentially been drawn too early and you may have to repeat it. But again, you can discontinue it based upon your level of suspicion. All right. So again, viral, what do I only care about? There's only two, HSV and VZV. Those are the only ones I care about. All the other ones, I'm not going to do anything with. It's going to be supportive care. TB meningitis, we don't often get this unless I have the particular concerns, but you'll get what's called, the mycobacterial cultures, and you'll even get on like acid-fast, staining to look to see if these things are present, right? Cryptococcal, again, I'm not doing this one all the time. I'm doing it if they have specific risk factors. And you'll do something called a cryptococcal antigen test, and sometimes they do an Indian ink smear, but if you ever had to pick between those two, always pick this one first. You get the point. When you're getting an LP, you're already having them covered for the most common. Antibiotics for bacterial and only adding viral coverage for the viral encephalitis like HSV or VZV if you have the concerns there. Once you get the cultures, the PCR testing back, you narrow it down. All right? I'm only going to cover these if I have the risk factors, and I'm going to test them for it if I have the degree of suspicion. That brings in the next question. When do I actually have suspicion to test for other things? It really depends on what they present to you in the vignette. The things that they would present with TB is they probably had some kind of recent travel to an endemic area. They're immunosuppressed, especially HIV patients, or they were in areas where there's high risk of exposure. Probably prisons. Those are a big one that they'll talk about. Homeless individuals, drug abusers. Those are people that you'd have that high degree of suspicion. And you would get the acid-fast stain. You'd get the mycobacterial culture. And you'd probably put them on a rape regimen of some sort. All right. The cryptococcal, I'm only going to do that if I have a patient who has AIDS and they probably say somewhere in that the CD4 count's less than 100. That means that that's an opportunistic infection for them. And I need to consider that. And then I'll put them on the proper therapy if I have that come back positive. Because once you put someone on amphotericin, it's a pretty nasty drug and you want to be sure of it. Neurocephalus is kind of a random one, but if I hear anything on the vignette of tabes dorsalis and Argyll-Robertson pupil, you get the VDRL, you get that kind of antibody, the fluorescent antibody testing to see if it comes back positive. Lyme meningitis, you're looking for, an erythema, migraines, rash. You're looking for, again, that bullseye rash presentation. But another thing that you're looking for is, do they have any neuro kind of presentations? Like, for example, bilateral facial nerve palsy is a giveaway. All right, bilateral facial nerve palsy, neuropathies, those are things to think about, and then potentially test them for Lyme, especially if they talk in the vignette about they traveled to the northeastern part of the United States and they were hiking, right? That's something to think about. With that being said, Naegleria, This one, the patients are sick as crap. I mean, they look horrible. Usually what they'll say in the vignette is there was a person who jumped into still water, whether it was a pool, they jumped into a pond, a river, and a lot of that freshwater source rushed up their nose that contained the amoeba, the Naegleria fowleri. And you'll test that. You'll actually look at it on a wet mount and you can do a PCR for it. But you're putting them on so many therapies that these patients are on, I'm not kidding, antibiotics, antivirals. They're on anti-cancer meds. It's so insane what you have to put them on, and usually they have a high rate of mortality. One thing again to add on, I kind of talked about it. You have a patient come in, fever, headache, meningeal signs. Maybe they have some cortical signs. They have no fail signs. You get the LP. You're kind of like waiting for that to give you back at least the first things. Usually the first thing that comes back is your glucose, your cell count, the differential, and then your protein. You're going to have to wait a little bit for the culture and the PCR. All right. That takes maybe about a day or two for you to get something like that back. And sometimes, depending upon what else you're testing for, even longer. So in those timeframes, you're treating them for what you suspect. When you're treating them for what you suspect, let's say that they're on an antibiotic, they're on an antiviral, because you think that they may have HSV encephalitis. If that PCR comes back negative, but you still have a high degree of suspicion, one thing I think that's always helpful to do that aids to the actual diagnosis and helps you have a little bit more confidence is to get an MRI. The reason why I say get the MRI is because sometimes the temporal lobes, they tend to be the most often affected. And so, for example, if I look at the MRI here, here's my right temporal lobe, here's my left temporal lobe. Do you see all this hyperintensity? All of this on that kind of that T2 flare has all of this kind of like hyperintensity, vasogenic edema. Classic of HSV encephalitis. Usually it can be bilateral and it's usually asymmetric, but it's almost always the medial temporal lobes that light up on T2 flare, especially with the clinical presentation of fever, headache, and some cortical signs. In that scenario, I would keep treating them, and I would also reorder the PCR to do it in about like 3 to 7 days. Keep treating them until that PCR comes back. But if you have a high degree of suspicion, definitely get the MRI. It adds to the utility of the diagnosis. It's not a guaranteed one. It's not like, oh, they have it, but it definitely helps you in those kinds of moments of uncertainty, if that makes sense. All right. We've gone through the processes of really determining if they have encephalitis, to determine if they have meningitis. Boom. What about that person who does have a mass lesion? So I get a CT scan. I see something like this. When I see something like this, I could think brain cancer. I could think about a brain mass, but I could also think about a brain abscess, especially if they have fevers and headaches and cortical signs. So always in these situations, get a better look. MRI with and without contrast is going to be the best way to go. It's going to look to see if it enhances. It's going to look to tell you if it's pyogenic or not, if it's non-pyogenic, and then you're going to have to assess the risk factors. Let's do this step by step. It's kind of taking it a little extra, and so you may not need to know this, but I think it helps you as you become a clinician. The first thing that you want to ask is, does it look pyogenic on MRI? What does that mean? A couple things that you look for, it's not always the case, but it definitely helps you, is looking at the clinical context. But also, when I look at these images, I have to go through a step by step. The first one is I want to look at the T2 weighted image. I can see kind of a mass here, but I see a lot of vasogenic edema. So we call this hyperintensity on the T2 weighted image. The next thing is, I also want to look at the ring enhancing lesion. This is usually on the post-contrast. Contrast will show ring enhancement. And that is usually indicative of some kind of breakdown in the blood-brain barrier that you can see in situations like abscesses. And so I want to see that kind of ring enhancement. You can also see this in cancers though too, right? So I want to see that ring enhancing. So ring enhancing lesion, T2 weighted image is going to show vasogenic edema. Both of this can happen in cancer and abscess. What may help is that whenever you have a pyogenic lesion, that actual kind of purulent material may come up bright on DWI. So you see how it's bright here, that's the DWI. And then ADC should be the opposite. It should be dark. And so we can have a dark lesion on ADC. If you have these particular findings, it suggests a higher likelihood of a brain abscess, especially a pyogenic one, than it does a non-pyogenic lesion of some sort. So that's what I want you to think about. Flare, I have hyperintensity. Contrast imaging, I see ring enhancement. DWI, bright. ADC, dark. If that's the case, the next question that you have to ask is there multiple or solitary brain lesions? Why do I ask that question? The reason why is because the location is then going to be the next thing. If I have a solitary lesion, I want to know, is it in the frontal lobe? Because if it's the frontal lobe, what's the area that what are the possible etiologies to suspect here? Because look, I got a nasty abscess here, right? what should I then say? Ooh, I should probably go and look for what type of causes that led to this. What are the big things to think about? I'd probably start thinking about things like a frontal ethmoid, sphenoid sinusitis. I'd be thinking about maybe a dental abscess or infection that spread there. That's what I'm starting to think about. Temporal abscesses, on the other hand, here I have an abscess. I have concerning features of what seems to be a temporal abscess. I've confirmed its findings that it's pyogenic on the MRI. What am I then going to start looking for? Looking at the mastoid, looking at the middle ear, right? So that's why I want you guys to think about that. So again, the source evaluation is critical because sometimes it guides how you're going to manage these patients. So for example, again, frontal, I'd do a really good ENT and dental exam to look to see if I find any sinus infections. Do I see any kind of opacification of the frontal, the ethmoid, the sphenoid sinuses? Do I see some bone erosion there? Do I look at the mastoid sinus and see that there's some bone erosion, opacification? Do I look at the middle ear and see that it's opacified and there's bone erosion, and that's the way it accessed itself into the brain? Those are important. So CT scan is also going to be super critical, along with just examining them first. Okay. Now, multiple lesions, I ask the question because when you have multiple, the first thing I ask is, where is those multiple lesions? Is it in the gray-white junction, or is it deeper in the brain or somewhere else? If I see a lot of them are on the gray-white junction, that means it was occurring along vascular territories. That means it was probably spread through the blood. So that means that this was a hematogenous spread. And that means I think infective endocarditis, and I think about a lung abscess. So here I can appreciate, look at all of these like ring-enhancing lesions, and they're multiple along multiple vascular territories. That would make me think right off the get-go of infective endocarditis. I'm going to get an echo right away. That's a question that you may be asked. The other one, a little bit less likely to be asked and kind of rare, especially in certain patients, they probably have to have a certain degree of immunosuppression as you think about nocardiosis. We'll talk about that in just a second, but with echocardiograms, you're going to be getting the blood cultures. We already ordered that. That's cooking in the meantime. But the echocardiogram will find if you have any vegetations. As we can see here, they have a vegetation for sure skis right there. All right. So that's the benefit of also ordering the blood cultures up front, because it may tell you the particular cause of their overall CNS infection. Oh, it's Staph aureus or it's Streptococcus viridans. And the source of it is from the echo, because we're going to follow that Duke criteria going back to infective endocarditis. All right, cool. The other one I told you, no cardiosis, get a chest CT. That's the one to also do a particular image for. They'll present with some features that concern you that are coming from the lungs. The chest CT will show you that they're probably going to have a lot of like areas of pneumonia with some loculated abscesses that are concerning for nocardia. All right, especially in patients who are immunosuppressed. All right. That's the pyogenic ones. What about the person who doesn't present with a pyogenic lesion? It doesn't show that T2 flare. It doesn't show a T2 weighted imaging with hyperintensity. It doesn't show the ring enhancement. It doesn't show the DWI that's bright and the ADC that's dark. It just kind of presents in a different way that doesn't support a brain abscess that is purulent in origin. It supports something else. In those scenarios, I then urge you to assess the MRI a little bit more to get an idea of where these are, what they look like, and then take into consideration their history along with, do I need to get HIV and specific serological testing? So history, do I need HIV tests? Do I need serology tests? And take a good look at their MRI and characterize it. Let me explain. If I get an MRI and I see lesions in the basal ganglia bilaterally like this, or maybe even unilaterally, if I see, again, ring enhancing kind of lesions here that present in the basal ganglia, that is highly concerning for toxoplasmosis. So what do? I get an HIV testing. Unless I know that they have an HIV positive, I would check the HIV, I would check their CD4 counts, all right? That's what I'm doing. If they have HIV, their CD4 is less than 100, I'm super concerned for toxoplasmosis. So what do? I get the serology test to test for the IgG antibodies of Toxoplasma gondii. And if that comes back positive, there's a high chance I got cerebral toxoplasmosis, right? For the other scenario, if the MRI shows these lesions that are, I'm not kidding, it looks like Swiss cheese and you have a hole everywhere with a small little dot in the center of it. This makes me concerned about a tapeworm, like Taenia solium. And this is usually the scolex of it. So there's just holes all over the place with dots in the middle of them all over the place. This is super concerning for neurocystericosis. The thing I'm looking for here in the history in some way, shape, or form is they're probably not HIV positive, but they've traveled to areas and they've kind of like that are more concerning, like Africa, South America. They tried some food that was a little funky in those areas. They got a tapeworm. It reached its way up to the brain and just wreaked havoc. That's what I'm looking for. All right. And in those scenarios, I would order the anti-cysticercal antibodies from their serum because their immune system should have had a reaction to it. And if those come back positive, it does add a degree of concern for neurocysticercosis. All right. So really, really critical that we do that. Now, the last thing I want to add is that we really don't always have to tap into these abscesses, or even in this case, the non-pyogenic brain abscess. You don't always have to do that. The reason why is you incur risk when you stick a needle, when you do anything into the brain tissue, especially depending upon location. So you should only do it if you have the particular indications to do that. And what are those? If the lesion is big, and it's a very arbitrary number, but anything greater than 2.5 centimeters, I prefer enough that the lesion is big enough that it's causing problems. Like, for example, if I have an abscess in the posterior fossa, that's already a small area. The problem with having a posterior fossal abscess is it can cause hydrocephalus. It can cause maybe some cranial nerve palsies. So with a posterior fossa abscess, I worry about herniation, I worry about hydrocephalus, I worry about cranial nerve palsy. So in those scenarios, I'm probably going to want to reduce the risk of that happening and test it. And also probably while I'm there, drain it because it's going to cause complications. Another one is if the actual abscess is causing like herniation symptoms. In other words, they're developing subfalcine, uncal herniation. They're having neurological deficits that are truly not getting better with antibiotics. And that's another one. They're not getting it better with antibiotics. That's probably the most likely one that you'll see on the exam. That would be a very strong indication to tap into it. The reason why is if I tap into it, I can test it for a particular pathogen that I'm not treating with accordingly. And sometimes I can even aspirate and drain it to just have source control. And so that's why it's really important to remember this one if you forget all the rest of them. The last one I also like to add on is if it's close to a ventricle. If an abscess is kind of close to a ventricle, it has a high risk of kind of fistulizing with that ventricle, if you want to think about that, and opening up into the ventricle and dumping that pus into the ventricle. And that can lead to communicating hydrocephalus, a lot of nasty stuff like ventriculitis. So really critical that we identify that as well. If that's the case, you better go ahead, tap into it, pull off that, send the cultures, send off all the tests to the lab. And then again, by doing some of that draining of it, you also may provide some therapeutic benefit of mass effect and associated complications from that, like a ventricular rupture, like mass effect, like posterior fossa leading to hydrocephalus, and maybe even some nerve palsies as well. All right. Woo-wee. Man, that was a lot for CNS infections, but I hope at the end of this that you get the whole point is that you need to first concern yourself with, is this a CNS infection? This is the way that you do it. You then need to say, I'm going to give them antibiotics, maybe antivirals if they have the concern for HSV encephalitis. But I want to make sure I get my culture so I don't sterilize those cultures. I then need to ask, do they have a risk of herniation or do they have a structural lesion? If they do, get the CT. If they don't, get the LP. If I get the CT and it doesn't show me any brain mass, but I still have concern that they have meningitis, you better get the LP. The LP is going to help you to determine if you have meningitis or encephalitis, especially HSV, VZV. And if you have those particular exposures and risk factors, you can go down the line to more rare etiologies. If you got that mass lesion, then you then got to figure out, is it pyogenic or not? If it's pyogenic, you then got to figure out where's the location, where did it come from? And if it's multiple, you then got to think about, again, where would I be concerned about it coming from? Infective endocarditis is probably the biggest one. And then if it's non-pyogenic, you always want to think about toxo, and you always want to think about your neurocysticercosis. All right, my friends, let's now move on to the treatment. So when we talk about treatment, we're going to focus a little bit on bacterial meningitis. So we got some nasty bugs in the meninges and it's causing some unfortunate infection, inflammation there. We just got to kind of remind ourselves, okay, when we're talking about this, what is the therapies that I'm going to institute? Well, antibiotics are going to be the key. But before I initiate antibiotics, it's kind of crucial, especially with streptococcus pneumonia. So we call this pneumococcal meningitis. It is extremely beneficial to give dexamethasone prior to the antibiotics. And so a lot of the times we can say with a lot of degree of certainty that when we talk about community-acquired meningitis, it's usually either strep pneumo, Neisseria meningitis, or Haemophilus influenza type B. And so we can start them off with dexamethasone. The benefit to potentially providing it before the antibiotics is that you may reduce the inflammatory reaction from whenever the antibiotics cause their bactericidal or bacteriostatic effects, which may lead to toxins and cytokine releases, and et cetera. You may be dampening that response prior. So that's one benefit. But again, the primary reason that we initiate this is to reduce neurodisability, maybe even potentially mortality, especially with pneumococcal meningitis. Again, we usually only continue this for about 4 days, especially if the cultures prove that it is Streptococcus pneumonia. All right. Oftentimes, by the time you actually get the cultures back, you're almost at the end of the dexamethasone anyway. So again, that's why we usually give it. Empirically, prior to the antibiotics, they're going to be placed on antibiotics. You'll get your cultures. By the time your cultures actually probably come back, you already have almost 3 days, 2 days of dexamethasone that you usually just finish it out or discontinue it. Now, with the antibiotics that we're talking about, it's critical to know your empiric coverage. So the most common coverage for a community-acquired type of, meningitis is you're covering strep pneumo, Neisseria meningitidis, and you're covering Haemophilus influenza. That's going to be your vancomycin and ceftriaxone. The vanc is going to cover any kind of pneumococcal resistant type of bacteria to ceftriaxone. So vancomycin will cover resistant pneumococcus to ceftriaxone, and the ceftriaxone will cover pneumococcus, and it'll also cover Neisseria meningitidis, and it'll cover Haemophilus influenza. Now, kind of go back to a little bit of your step one, your basic sciences here, that we have a cell wall, we have your cell membrane, you have your cytoplasm, you got a bunch of other structures here. This is a pathway that makes tetrahydrofolate that's incorporated into the DNA. DNA is obviously crucial for replication of cells. You have a lot of enzymes that are critical to that, especially topoisomerases and DNA polymerases. From DNA, you make RNA, and RNA is then translated to make proteins, which utilize ribosomes like the 50S and the 30S. And there's obviously so many different proteins that are crucial to the structure of a lot of our cells. So when I talk about this, the reason why I tell you this is that it's a good reminder to think about how vancomycin and ceftriaxone really work. And what they do is they work against cell wall synthesis. They're going to break down the cell wall. And that's going to make it easier for these cells, unfortunately, to die. And that's one of the benefits of these drugs. Now, you can do that in 2 ways. If you remember, you can decrease the synthesis of the peptidoglycans that make up your cell wall, or you can also do it by decreasing the cross-linking of the peptidoglycans, which is the benefit of ceftriaxone. All right, so just a quick little reminder for those of you who are thinking about that step one stuff. Either way, this is empiric coverage for those individuals less than 50 years of age. All right. The next therapy is your vancomycin plus ceftriaxone, adding on ampicillin. Ampicillin, again, is just going to act similar to ceftriaxone. It's going to break down the cell walls. But the important question to ask is, when do I use it? And we use it for those individuals who are greater than 50, or they have other particular risk factors for listeria. Greater than 50, immunosuppressed, pre-existing conditions like alcoholism or cirrhosis or pregnancy. Those are the things that make you highly suspicious of listeria, so you add on the ampicillin. All right. Next one, vancomycin, cefepime, or meropenem. When do I do this one? Again, if a patient comes in, they're getting dexamethasone. The empiric coverage is this. The only time I add on the ampicillin is if I have indications for listeria. The other scenario where I may not even use ampicillin, I may not use ceftriaxone, is when I have a patient who is concerned that they may have an infection due to hospital-acquired pathogens. And that's when I may use something like cefepime, which again, it's going to inhibit the cell wall synthesis, and meropenem is going to inhibit the cell wall synthesis. It's a beautiful thing that almost all of these inhibit the cell wall synthesis. What I want you to remember here is, when do I use them? I use them in a hospital-acquired infection scenario where I need to cover a patient who had a neurosurgical procedure, they had a cranial device like a EVD, a VP shunt, an Ommaya reservoir, something where there was access to their central nervous system. And in that scenario, they had an increased risk of MRSA and Pseudomonas. And so I need to consider that. Or they have a penetrating trauma, whether this was unfortunately due to getting hit in the head by a machete, they got cracked in the skull, whatever it may be. Those are opportunities for pathogens like MRSA and also Pseudomonas to get their way in. And that's why we add on cefepime, or we can do meropenem, because meropenem covers Pseudomonas, and it also can cover a lot of your gram-negs and even anaerobes as well. So Vanco covers your MRSA, cefepime or meropenem can get you some of that Pseudomonas coverage and even anaerobes and other gram-neg coverage. All right. So again, the way I want you to think about it is, patient comes in, they get dexamethasone if they have a concern of bacterial meningitis. Then after that, you add on vanc and ceftriaxone if they're less than 50. If they're greater than 50, they have predisposing risk factors like immunosuppressed or they're alcoholic, cirrhotics, pregnant, you add on ampicillin to the vancomycin. If they have a concern for MRSA or Pseudomonas from these potential scenarios, you still give vanc to cover the MRSA, but instead of giving ceftriaxone and ampicillin, you switch it to cefepime or meropenem to cover the Pseudomonas. That's the difference. I hope that makes sense. All right, the last thing I want to tell you guys is that we have to remember when a patient has meningitis, especially bacterial meningitis, it is critical to know if a patient has Neisseria meningitis, right? Now, again, we're going to cover Neisseria with the ceftriaxone, right? And they're going to be on these antibiotics for a decent amount of time. One of the important things is to have that kind of like overall contact exposure for those that are going into the hospital to visit this patient. But it's also critical for those who had close contact. So a loved one, a family member, someone who was around this person a lot, they need to be treated prophylactically with the proper antibiotics. And so what may happen is in the exam, they're going to say, okay, you have a patient, you end up confirming they have Neisseria meningitis, you then narrow your antibiotics down to ceftriaxone, but then you're asked what type of antibiotic do you prescribe the family member who lives at home and was exposed all the time to this patient? What is it? You have three options. One is rifampin, 2, ciprofloxacin, 3, ceftriaxone. So that is what I want you guys to remember. This is a really high yield point that'll likely come up, is that we want to give close contact antibiotic prophylaxis to those who have Neisseria meningitis. Again, if they have been diagnosed with it, the loved ones who live with them, anybody who had close contact exposure should be treated with one of these three agents. HSV or even VZV encephalitis is treated with acyclovir. All right, acyclovir is a beautiful kind of drug, but it can cause some nephrotoxicity. And so we always have to be aware of that. But how viruses really work, especially in a neuron, is they bind to a receptor, they get endocytosed, they then get taken into the cell where they release their kind of their virus particles, their nuclear material, their enzymes. And then what happens is they oftentimes can get reassembled, incorporated into the DNA, and they kind of reassemble their own viruses, which then unfortunately can then get pushed out and go to another cell. And in that process, they can cause lysis and destruction of this cell. What I want to do is I want to prevent this virus from going on and infecting other cells. I want to reduce neuron damage and the progression. How do I do that? I need to inhibit a particular point in the cycle. And that is where I'm going to inhibit them from synthesizing new nucleic acids for new viral particles. And usually how acyclovir will work is it'll act as a nucleoside analog, so guanosine analogs, where they try to get incorporated into the DNA and terminate DNA formation, synthesis, replication. And that's the benefit of acyclovir, which is really good in HSV, good in VZV. And you also have ganciclovir, can also act in this way, and that's good particularly more with CMV infections. All right, again, when do we cover HSV with acyclovir? We do it in a patient who's already on empiric antibiotic coverage for meningitis, and they are on dexamethasone, but you cannot rule out encephalitis. In other words, they present with seizures, they present with cognitive behavioral changes, altered mental status. And I'm waiting on the LP to give me my PCR results. Until that comes back, and I have a high degree of suspicion, I keep them on acyclovir. If it comes back positive, get rid of the antibiotics, get rid of the steroids, and keep them only on acyclovir. That's the concept. So it's usually given in combination with empiric antibiotics and dexamethasone. But again, once you actually get that PCR to prove that they have HSV or VZV, get rid of the other ones and only keep them on acyclovir. All right, that is the primary indication. So it's a part of empiric coverage, but it's going to be definitive therapy if it's confirmed HSV or VZV encephalitis primarily. You can consider it a meningitis, it's just less common. All right, brain abscesses. These are some nasty infections, man. And when you give antibiotics, you're trying to cover a plethora of pathogens. Vancomycin, again, it's inhibiting the cell wall synthesis. Ceftriaxone, inhibiting the cell wall synthesis. Metronidazole, a little bit different. This one doesn't actually work against the cell wall synthesis. It actually creates like these kind of like reactive oxygen species and essentially it damages the DNA. So again, your bacteria is not going to be able to properly replicate. All right. This is your empiric coverage. You give this to patients who you have no idea what the source is of their brain abscess. So you find an abscess, all right, start them on vanc, start them on ceftriaxone, start them on metronidazole. Why? Because the vanc is going to cover any kind of pathogen like Staphylococcus aureus, right? Especially MRSA related. Ceftriaxone is going to cover a lot of your other pathogens like streptococcal species. And then metronidazole is going to cover any chance of anaerobes, especially if this came from a dental source like Bacteroides fragilis or Fusobacterium. Those are some really nasty ones. And so you want your MRSA coverage, you want your streptococcal coverage, and any other kind of gram negs, but this one's going to really get your potential for anaerobes. All right. Now, if you know the source, it makes it a little bit easier. So for example, metronidazole and ceftriaxone, that means you're covering your anaerobes and you're covering probably most likely your streptococcus species like the viridans and pneumonia. So that's going to be potentially more of that dental and cyanogenic source and otogenic source. So it's coming from the ear, it's coming from the actual teeth, or it's coming from the sinuses. Vancomycin and ceftriaxone, you're dropping the anaerobe coverage. So if I don't have anaerobes, that's probably screaming to me more likely this is coming from a hematogenous source. So I'm really trying to cover things like strep and MRSA, which is infective endocarditis. That's where you'd be thinking about that one. So if I had a patient, essentially, if they came in the vignette and they had a MRI that showed multiple ring-enhancing lesions along the gray-white junction, they have a new onset heart murmur, fever, they have other features of infective endocarditis, echoes positive, and they say, what's the proper therapy to treat this abscess? You would say vancomycin and ceftriaxone, because it's going to cover the most likely pathogens for that scenario. Now, the only time we'll really amp up our game and cover it with vancomycin and cefepime is if I have a concern for MRSA, but here's the other one, Pseudomonas. And this can actually cover your Pseudomonas as well. So when we think about that, we got to really be concerned. What would be a scenario where I would be exposed to things like, strep species and staph species and Pseudomonas? What would I be thinking about? I'd be thinking about some type of direct inoculation, a neurosurgical procedure of some sort, a cranial device that was inserted in a penetrating trauma. But really, that is the thing I want you to think about here. Just as a reminder, meningitis that is bacterial, dexamethasone. If it's usually those less than 50, vanc and ceftriaxone, and you'll be safe. If you have the listeria concern, add ampicillin. If you have a patient who probably presents with a hospital-acquired or penetrating-related trauma, you need to cover MRSA and you need to cover Pseudomonas. That's vanc, and then instead of doing ceftriaxone or ampicillin, you switch it over to cefepime, or you use something, what else? Meropenem. For the HSV encephalitis, if you have a concern of encephalitis and you can't prove that they don't have it, as you get the LP, as you get the PCR and you're waiting, give them acyclovir, a part of that empiric coverage that you covered with the bacteria. Add on the acyclovir. Once it comes back positive for HSV or VZV, continue and get rid of the rest of them. That is the goal. Now, for brain abscess, if you have no idea of the source, cover them for anything possible. Cover them for things where you have anaerobes and you have strep. Cover them for things where it could be a hematogenous source, right? But for those who you are very concerned for Pseudomonas, you cover them with the cefepime. You consider things like the MRSA coverage, or you can do monotherapy meropenem, all right? That is what I want you guys to take away from this. All right, what about treatment of complications that can come from CNS infections? Seizures are really, really common, especially with encephalitis. You can see with brain abscesses and probably also possibly with meningitis, because all of them can lead to cortical irritation. So the big thing to remember for this is when we think about the way seizures really work, you have a presynaptic neuron, you have a postsynaptic neuron. This is an area that generally what's happening is you have a neuron that can release something called GABA. And what GABA does on that postsynaptic neuron, and it binds onto a GABA receptor, and it controls chloride ion influx, which can then kind of inhibit that neuron, right? Well, if I want to kind of enhance that mechanism, what would I do? I would give a benzodiazepine. And the benefit to giving a benzo is that it's going to help to stimulate, it's act as an agonist and binds onto that receptor and enhances chloride ion influx. Now I got a crap ton of chloride in this neuron. It's going to then inhibit that neuron's postsynaptic action potentials. That's what we give for the first line if a patient presents with status epilepticus. In other words, they seize for greater than or equal to 5 minutes. They seize consistently without returning to baseline. That would be an indication. And then from there, you want to prevent the recurrence of those seizures. And so that's where another concept comes in. You know, neurons, not only do they have this GABA pathway, they have a glutamate pathway. And that's controlled via these voltage-gated sodium channels. They cause sodium to rush in, depolarizes, opens up these calcium channels to rush in. Calcium is crucial because what it really helps with is it helps these vesicles that contain glutamate to then fuse with the actual membrane and release the glutamate. What glutamate does is it binds to these AMPA receptors and other receptors and flushes in sodium, can flush in calcium as well, and that's going to activate the neuron, right? Another thing is that glutamate gets recycled and it gets brought back into the neuron where it can be put back into these vesicles, and this can be helped with this SV2A process. This is a molecule, this synaptic vesicle protein. What I can do is I can give a drug called levetiracetam, which is called Keppra. And what it does is it inhibits that SV2A. It inhibits it from then allowing for this to fuse with the cell membrane, drops the glutamate, drops the sodium, and drops that postsynaptic neuron action potential. Essentially, it's the same thing as a benzo, but these are better for what? Preventing recurrence. And that is the thing I want you guys to remember. So this is more of that prophylaxis, if you will. So if a patient presents with a seizure and they continue to seize, benzo, but then preventing them from seizing in the future, the answer is an anti-epileptic. And the most commonly utilized one is going to be levetiracetam, just due to its overall reduction in adverse effects and side effects. All right. Hydrocephalus. We talked about this as a complication, can occur in meningitis, can occur a lot in brain abscesses, whether it's obstructive, whether it's communicating. Whenever a patient has another condition called cryptococcal meningitis, we can do serial LPs. It's better than putting in an EVD. It's better than kind of actually sometimes putting in VP shunts because they get clogged up a lot from the heavy amounts of protein. And so we prefer to do LPs pretty frequently to really reduce that pressure in some of that hydrocephalus. So it's just like you would do an LP, you're just accessing it instead of actually kind of, in this case, measuring. You can still measure the opening pressure. You can still accumulate all of these in test tubes, but you're just trying to drain CSF in these scenarios because of the communicating hydrocephalus process to reduce the hydrocephalus and the associated increase in the ICP. All right. Now, EVDs are really going to be more in the acute scenario. So if I have a patient with cryptococcal meningitis and they say, which one would you do to reduce the hydrocephalus? You'll say serial LPs. If I had a patient who had not cryptococcal meningitis, but they had meningitis, they had obstructive hydrocephalus from a brain abscess, and they're having severe hydrocephalus, their ICP is starting to rise, what do? It's always an EVD. It's the acute management of hydrocephalus. That's what you're going to use it for. All right. The concept behind this is that if you have your ventricles, right, what you want to do is you want to use a catheter, thread it into the actual ventricles. And if let's say that there's hydrocephalus, it's all the way up at the arachnoid villi, right? All this pressure builds up kind of all proximal to it. Or if you have an obstruction somewhere, let's say here in like the cerebral aqueduct of the fourth ventricle, you want to pull all the fluid off that's accumulating proximal to that. And so that's where we use this catheter to drain some of that CSF. And if we drain the CSF, we can actually reduce the hydrocephalus and the associated increased intracranial pressure. Now, long term, if a patient continues to suffer from hydrocephalus and we just can't wean them to get them the EVD out permanently, we may need to bridge them to something called a VP shunt. And that's just a little bit more of a long-term option where we're just running the catheter from the ventricles instead of to a thing where it can drain into a bag. We're going to just drain this right into the peritoneal cavity. And that's an alternative, but that's going to be more of the long-term approach. That's what I want you guys to think about there. All right, that's hydrocephalus. So we talked about seizures. We talked about hydrocephalus. Now, hydrocephalus can cause a bump in the patient's ICP. When a patient experiences a high ICP, that's common with meningitis. It can be common with encephalitis, especially if they're seizing like crazy, that increases the ICP. But brain abscesses can cause a pretty significant increase in ICP because there's a mass effect. They also increase the risk of obstructive hydrocephalus. So this is common with all of them. What you always want to do when a patient presents with an ICP crisis, their ICP is really, really high, greater than or equal to 20. They're presenting with neurological signs of herniation. First thing you do is you temporize them. These things aren't going to fix the problem. They're going to keep them from dying. What is those things? You're going to get the head of the bed greater than 30 degrees. It's going to help the jugular venous drainage, get the blood out of the brain to reduce the actual overall that Monro-Kelly doctrine, get some of the blood to decrease all the structures that are components that are making up that fixed space. Again, if I drop the blood and get some of the blood out, that reduces the blood inside of the actual skull, and that reduces the ICP. Another one is hyperventilating. That reduces blood flow to the brain. Reduces blood, reduces the ICP. Analgesia and sedation, that actually reduces the basal metabolic rate. So the neurons aren't as hungry. They're not requiring as much blood flow. They're not requiring as much metabolism. And so that reduces, again, the theory of bringing more blood flow and demand to those actual angry and irritated areas of the brain. Hyperosmolar therapy is really trying to reduce the size. And so it's actually pulling fluid. This is things like mannitol and hypertonic saline. And that's going to pull some of the fluid out of those actual brain cells and to make space inside of the skull. All right. So it's going to reduce some of the edema. These are just temporary. If you don't fix the underlying issue, they will herniate regardless. And so it's important to remember to do this for whenever the ICP reading on the EVD shows up greater than 20, or you have clinical evidence. In other words, they have papilledema, nausea, vomiting, diplopia. They have signs of subfalcine, uncal herniation, transtentorial herniation, anything like that. Or they have radiographic evidence in combination with that. So in other words, they have clinical signs and their CT shows that they're subfalcine herniation. It shows that they're having uncal herniation. It shows that they're having transtentorial herniation. Give them the temporizing measures. All of this is useless if you actually don't treat the underlying issue, right? And so you have to think about this. You're trying to do these things to kind of keep their ICP at bay while you're trying to figure out what's the ultimate reason that their ICP is high. And it goes back to the Monro-Kelly doctrine. Is it an abscess that's increasing the amount of brain tissue and overall substrate? Is it a problem with overall CSF? Is it a problem with blood that shouldn't be there or more blood that's there than normal? And so in none of these situations is it really a blood problem. It's usually just brain substrate, in this case an abscess, or you have a lot of hydrocephalus that's causing an increase in the amount of CSF. So what are the two ways that we deal with that? I already talked to you about the CSF one. That's an EVD. That's acute management. You may need a VP shunt long term, but at least acutely, it's an EVD for that hydrocephalus. The brain abscess, you're trying to treat that with antibiotics, but if it's causing things like herniation, right, then you got to go ahead and drain these puppies. And that's when doing a surgical abscess removal or a drain, reaching out to neurosurgery is going to be strong indication. And so one of the neurosurgery teams is probably going to ask you, okay, why do they need it? Well, having an ICP crisis is a pretty good indication as long as you have treated other areas of issues. But at least tell them, well, the abscess is greater than or equal to 2.5 centimeters. But more importantly, it's in the posterior fossa, so it's causing a lot of mass effect on the patient's ventricles. It's causing some other kind of neurological signs of herniation. Another one is they have visible mass effect causing things like subfalcine, uncal herniation because of the location of where that abscess is. Another one is if they aren't getting better with antibiotics. So you put them on antibiotics and the abscess continues to not change or not get better or gets worse somehow, you need to definitely go ahead and drain that and then send that off to figure out what the heck is going on. But another one is if it's really close to a ventricle, because if those ventricles, if that abscess ruptures into that ventricle, they're going to get ventriculitis, they're going to get worsening hydrocephalus, and they're not going to do well. So you need to always be quick to try to drain those abscesses and remove them if they fit the criteria for ultimate treatment issues that are going to, if you don't fix it, are going to continue to cause ICP crises to persist. So again, how do we do this? You can do this. Sometimes you can do it stereotactically where you kind of really hone in and you try to suck out all the pus in that area. Or you'd go through this in a surgical kind of drain way or removal where I'm going to literally drill through into the area of location where it's the prominent area. Obviously, subcortical ones are a little bit more difficult and you probably reach for more on these areas of doing an alternative therapy. But generally in this one, I'm going to go ahead and just maybe create an area where I can drill through the skull, open it up and expose the area of interest and then help to remove. And, generally you're going to help to remove a lot of that abscess material in that scenario. But again, I think that gives you the point. So patient comes in, they seize benzos to get them to stop seizing if they fit status epilepticus criteria, prevent them from seizing with levetiracetam, hydrocephalus. If it's Problems where they're having hydra due to cryptococcal, serial LPs are better than an EVD. Any other indication of hydrocephalus besides that, EVD. Long term, they need it because they can't get off the EVD, VP shunt. And then lastly, if the ICP crisis, temporizing measure, but then fix the issue. If it's a CSF problem, EVD. If it's an abscess causing mass effect problem, surgical drain or removal. Surgical abscess removal or draining of that kind of abscess. Another complication comes especially from meningitis and brain abscess. They oftentimes kind of co-align with one another, especially an infection started somewhere in the nasal, like a sinusitis of sorts or a dental infection, or even sometimes even in the otogenic ones. They can spread and they can cause abscesses, and they also can cause associated like septic thrombophlebitis, where they can cause cerebrovenous sinus thrombosis. You're going to treat these patients with antibiotics if it's an infectious etiology, but anticoagulation is critical so that the clot doesn't propagate and get any worse. So you have to put them on things like low molecular weight heparin. It's more preferred than unfractionated heparin. If they continue to have that clot get bigger, or they start to have ICP crises, then we actually make the risk of going in and reaching out to the IR team and going up endovascularly and trying to remove the clot out of the veins, which is a risky kind of procedure. So it's only if they're not getting better with anticoagulation that clot continues to propagate and get worse, or they're like severe. They have an ICP crisis and there's the only option. You can do things where you go in there and you aspirate it. You can sometimes even use like a mechanical thrombectomy and retrieve it that way. Sometimes you can even go in and kind of release thrombolytic materials like TPA to break it down. And then sometimes you can actually just use an angiojet and kind of pull that sucker right back that way. And then we have even seen the balloon stabilized aspirations as well. Either way, these are getting more into the details of ways that the interventional kind of like radiologist will go about this. The whole point is I'll consider thrombectomy if they're not getting better with anticoagulation, or they're experiencing an ICP crisis and I have no other option, because anticoagulation isn't going to get rid of the clot right away. I need more endovascular therapies. All right. Woo-wee! We did it, my friends. We went through CNS infections. We dug deep. I think we got through it. And I really hope that at the end of the day, you understand it. I hope that, when you have a patient who presents with concerning features of a fever and a headache and maybe some meningeal and cortical signs, you know the steps to take. You know how to cover these patients empirically for the most likely pathogen. How do you utilize these kind of cultures to guide which antibiotic to narrow down to? When do I add antiviral coverage? When do I add the fungal coverage, etc.? These are all critical things to know and understand. But man, I hope that you guys liked this video. I hope that you learned a lot. I hope it made sense. And Ninjas, I love you guys. So thank you guys. And as always, until next time.